Namaste to everyone over here. So good morning and thank you everyone for being here with us today. We are pleased to welcome you all on behalf of CCRN to the seminar on yoga and integrative oncology on the occasion of World Cancer Day, which is being celebrated every year on 4th of February to raise awareness of cancer and to encourage its prevention, detection, and treatment. The prevalence of integrative medicine approach has transformed patient care in many specialties, especially oncology. The primary goal of World Cancer Day is to significantly reduce illness and death caused by cancer. The cancer therapy aims at destroying tumors and helps in survival of the patients. But the diagnosis of cancer and its treatment cause significant physical, emotional, and psychological discomfort that has an effect on the functional quality of life. So other interventions that minimize treatment-related anxiety and increase in the quality of life are considered very much essential. So in this juncture, yoga is one such mind-body therapy or intervention that has become increasingly popular in cancer patients due to its potential to decrease physical and emotional symptoms like decrease in fatigue, pain, anxiety, depression, and insomnia, and also improves flexibility, balance, mood, and overall quality of life. Therefore, to deliberate on various beneficial role of integrating yoga therapy into the oncology care, we have with us today the eminent speakers specialized in oncology as well as in yoga. So in the first session, we have Dr. Suchitra Mehta and Dr. Jayita Diora will be discussing on symptom burden on psychological issues in cancer patients. And in the second technical session, we have Dr. Anuja Damani, Dr. Shushma Bhatnagar, who are going to deliberate on palliative care issues in cancer patients. In the final session, we have with us Dr. Nagaratna and Dr. Vinoda Kuchipillai to discuss about the role of yoga in cancer patients. Now, let us move on quickly for the inaugural session with our esteemed dignitaries and guest of honor, Dr. Bhushan Patwarzanji, Guruji Dr. H.R. Nagendraji, and Shri Vikram Singhji. But now I request our Director of CCRN, Dr. Raghavendra Rao, to continue with the inaugural session. And sir, please continue, sir. Take over the session, sir.
So thank you, Dr. Anusuya, and welcome all of you to this World Cancer Day celebrations, which is done every year on February 4th. So I'd like to introduce a very prolific researcher, a guide, and mentor who is here amongst us and was given his time to be on this August occasion. Professor Dr. Bhushan Patwarzanji, who is also the National Research Professor in Ministry of Ayush, and he was also the Vice Chairman of UGC also earlier. And we have a very, very distinguished researcher who's been very passionate about Ayush. He's a researcher from the basic sciences background, but has contributed a lot in the field of Ayush. And he's also been the guiding force behind the Journal of Integrative Medicine, Ayurveda and Integrative Medicine. So I welcome you here, sir, for this session. And we request you to give a few thoughts on this particular deliberations.
Namaskar. Dr. Rao and all at CCRYN. Am I audible?
You're audible, sir.
Thank you for this kind invitation. And actually, I must tell you that India during last 6-7 years has done remarkable progress in the area of treatment and management of cancer, and majority of the credit should go to yoga. And Dr. Nagendra, Dr. Nagaratna, and the entire SVSA team has done some outstanding research in collaboration with some of the top institutes all over the world. And this has given yoga a good visibility in scientific domains as well. I have done some psychometric studies as well, which indicates that the popularity of yoga during these years has tremendously increased globally, and in fact, it is now much more when you compare it with say Chinese traditional medicine. Guruji, yoga is much more now, and thanks to you and the entire team, and Ministry of Ayush has been driving this very well. I'm happy to see here Dr. Vikram Singh. I hope Dr. Kotecha also would join, who has given tremendous leadership to this sector. Uh, I also would like to tell you that if you look at the causes of death or leading causes of death, from 2015 to 2021, you will see that consistently cancer is on number 2. If we talk about the data from US, because that is the data available, we don't have data of many countries, but US data, if you see, and that if we take as an example, cancer remains on number 2. The first is, of course, cardiovascular diseases, followed by cancer. And this year, the third place, which earlier was unintentional injury, is now taken over by the COVID. Why I mentioned this is, I think this year's data indicates that globally, we lost 10 million lives due to cancer. So this is something which is very worrying. And cancer treatment will not come only through chemotherapy. Let me tell you, being from biological sciences, I can tell you that there is not going to be any magic bullet for disease like cancer. We will have to really strengthen our mind. We'll have to really strengthen our immune system. We'll have to strengthen our whole endocrinal system, what we call it as immune endocrine neuroaxis, that is the place where cancer treatment lies. And the whole thing is beautifully managed by yoga, both through physical asana as well as meditation and the neurological modifications that happen in our body. And in this context, I am sure that the work, I have seen some of the research work that has come out from CCRYN, and I must compliment Dr. Rao, especially before even coming to CCRYN. Dr. Rao has been involved with some of the top cancer hospitals, wherein his team has shown benefits of yoga therapy in cancer. I hope that such efforts increase, such collaborations expand, and India continues to be a leader in the field of yoga and non-pharmacological interventions, not only for cancer, but all those lifestyle diseases which world is looking solutions for. Namaskar. I hope and pray on this World Cancer Day that soon we will be able to manage cancer, if not conquer, because I still believe that war against cancer, this should not be war. We'll have to live with it. It is, and the treatment should be gentle and not very harsh. Every time killing cancer cells may not allow you to win the war. So this gentle approach, which yoga, Ayurveda, and Ayush systems provide, will be extremely valuable for the world. And so again, thank you for inviting me for this event, and wish you all the best.
Thank you, Dr. Bhushanji, for your very kind words. It's heartening to hear such encouraging words from a researcher like you. And surely with your guidance and your mentorship, Ministry of Ayush as well as CCRN is going to go ahead and implement some of the thoughts and collaborations with AIMS and other institutions like HCG and SVIASA and even Pune University, where you are also from. So where we can do some collaborative research and achieve such good outcomes where we can publish it in impactful journals. Now I call upon my mentor and my dear friend as well, I can say, Guruji H.R. Nagendraji, who is the Chancellor of SVIASA University. He is the guiding force behind us in taking up research about 20 years back. And he is the one who started encouraging me to work in the area of cancer. Because during those times in 1990s, nothing was known about using yoga interventions in cancer. Whatever popularity of yoga was there, it was there mostly for management of back pain, hypertension, diabetes, heart disease, or asthma. Okay, and this was cancer was a new area altogether. It had a lot of challenges and scope, and it was during that time where Dr. H.R. Nagendraji had guided us to take up this research in this area of cancer. That was in 1998, and since then we have seen a lot of research happening in this area thanks to his leadership and his guidance and mentorship. We have been able to go to great heights to do international collaborations with grants from NCI and etc. So I call upon Dr. H.R. Nagesh to say a few words on the way forward and how we can integrate yoga truly into oncology care.
Namaskar, my dear brothers and sisters. I congratulate Ministry of Ayush and CCRYN for organizing this wonderful day-long program on this auspicious World Cancer Day. Vikram Singh ji, I also congratulate you, your team, for helping Dr. Raghavendra Rao to take up this thing and make a very good seminar day today. And many of you know, as rightly said by Bhushan ji, that the matter-based paradigm of upward causation of modern science cannot solve our challenges today because it's one-dimensional. We think that everything is physical. The physical world is everything. And there is nothing like mind or intellect or emotions, everything, apart from what we have in the thing. If I ask a question, can mind exist without the brain, without the body? Almost 99.99% people say, no, impossible. But according to the ancient science of India, we are not just this physical body, we have 4 more bodies. And this world is not only the physical electromagnetic field, but there's the bioplasmic field, astral field, there's the bliss field, and information field. The 5 layers are all in continual interaction. And therefore, mind can exist. For example, when you die, all our personality traits are inherited in our samskaras, it's in the mind field. And when we come back, all those personality traits are going to come back. And therefore, we believe that in our ancient science, which is more comprehensive, more exhaustive, we have to find the root cause for this cancer. Because cancer is not just a single dimension thing. Then we would have solved it, like infectious diseases. But the mental restlessness, emotional upsurges, deep-rooted psychological conflict, the lifestyle, the dietetic change, all this contribute in a multidimensional way to cancer. And therefore, to look at only the root cause in the body, either in the brain or in the immune system or in the genetic thing, is not going to solve our problem. We have to look at man in his totality. Therefore, right from beginning, when we started this journey in 1986 with Kidwai Memorial Institute of Oncology, where we had all the burnt up cases, 6 of them when they came, Dr. Krishna Bhargava, who was the director, he said, you have to go to yoga, but we cannot do anything. We have finished chemotherapy, radiotherapy, and surgery. And they had bone cancer and breast cancer and the leukemia. All these people came to us, and we started trying to look at man in his totality and started bringing yoga as an adjunct to whatever they had. And we started finding remarkable improvements. All those people who were declared dead in 6 months, they lived for 10 years, 15 years, wonderful quality of life. This encouraged the huge Kidwai Memorial Institute of Oncology. Every day outpatient, they have about 300, 500,000 people coming. And he said that, why don't we introduce yoga in the hospital? 1987, 88, we started doing that. People started feeling so good. And this helped us to start off our journey of the randomized controlled trials and things in the pre-post simple studies also we started growing continuously. The whole approach was to see what is the root cause for this thing according to yoga. You know, according to Patanjali, we have got 5 dimensions of mind. That is the pramana, viparya, vikalpa, nidra, smritayaha. Pramana is the right knowledge. Viparya is the wrong knowledge. And vikalpa is the uncontrolled speed of the mind, the random mind, the haphazard mind. So viparya is the wrong knowledge. Seeing a ghost in a post, seeing a serpent in a rope is called viparya. And we started seeing that probably in the immune system, the viparya has set in. From the monomaya kosha to come to the physical body at the immune system. We know that cancer cells are not the cells coming from outside. They're all born in the body. When you create 1 billion cells in the body, maybe 1,000, 2,000, 5,000 cells, maybe the naughty cells, naughty children, and they are the cancer cells. Normally, our immune system takes care of it. But somehow this viparya comes and this immune system thinks that these cancer cells are my good friends. Then you have the problem. And that's what thing. So that viparya, which has descended out from the mind level down to the things, would have caused. And therefore, we know that the immune system getting stay high allows this cancer to grow. When it becomes substantial, then we have the chemotherapy to cut it and do the radiation to kill it. That is the war that we have against cancer. As rightly said by Bhushanji, this will not work. You have to have the development of the immune system to remove that wrong notion, to remove the suppressed immune system. You know, the stress is a strong immunosuppressant factor. Unless you remove that stress, you'll not be able to do this thing. Therefore, removal of stress, reduction of stress is key essence. Therefore, we started giving very deep relaxation techniques at the body level and slowing down of the breath at the breathing level and calming down of the mind by deep meditation and giving the proper counseling to see that it works at the highest level of information field. And of course, the diet plays a very important role. And this has been already prescribed with the modern medicine. What is the good diet of this thing? But we also started bringing out the dimension of sattvic diet instead of just tamasic or rajasic food, which is the quality of the food. Quantity of the food is one, quality of food is another. According to Ayurveda, have Vata Pitta Kapha, so we have to also look into that. Therefore, the diet therapy also plays an important role. When we did this, then we got wonderful results. Therefore, our first project in MD Anderson Cancer Center, we wrote, and they got about $700,000 for the pilot study on about 35 people to use yoga as an adjunct in the radiation therapy. And the results came out exceedingly well in 3 years, and we published 3 beautiful research papers in high impact fact journals. And based on that, we wrote a bigger project with the MD Anderson Cancer Center, and that was gifted by nearly $5 million. It is almost 5 years now. We have completed the study on 660 patients in a 3-arm trial and see whether relaxation is a real component and there's something deeper in yoga. So the 3-arm trial had the physical exercise, the relaxation thing, and the yoga dimensions, 3-arm. And then Dr. Andrew, our Lorenzo Cohen was the key factor in MD Anderson, and we have completed huge data has come. And we are trying to find out what are all those subtle things which have come out in this big data analysis. And that way we'll be able to show. Results have been quite good, but see how best this thing can be brought forward. What are those new components that are going to come up and be deciphered by the big data analysis that we are doing? And probably in another 5 to 6 months, we'll be able to bring this out in the best journals of the cancer. And in the meantime, in our Arogadama, a lot of cancers have started coming and wonderful results. People, mild, moderate, severe people, and those who are almost burnt up by these things, they come here and they get wonderful results. And therefore, an integrated approach of the eye system along with the aspect of the modern medicine should bring us the right thing. So in all cancer hospitals, we want that the addition of yoga, which is acceptable to everybody, if not Ayurveda or Siddha or Unani or homeopathy, they have had to proven these things, they can be easily adopted. And even while lying down in the bed, we'll be able to bring about these things. Simple practices we have done for advanced technique, chronic energization technique, mind soundness technique, mind imagery technique, mastering the emotions technique, Vijnana Sadhana Kaushala, ANAMS, all 6 programs that we have done can be done even lying down on the bed. And therefore, this is a wonderful tool which I should spread everywhere. Therefore, always our Dr. Harshvardhan says, you have done wonderful rate. It has not gone into hospitals. It has not got into nursing homes. So, as rightly said, for the wonderful contribution of Ayush for COVID, it has to spread everywhere. Dr. Rajesh Koteja was so right in bringing all the experts to see how best it can be spread throughout the country by media, social media. Every hospital should do that. So I want that in every Ayush hospital, at least, we should treat and see that yoga is brought forth. And even the modern medical system, many of the hospitals have started coming. In Bangalore, at least about 8 hospitals. In all cancer treatment, we are bringing yoga. And thanks to Dr. Raghavendra, who did wonderful work in this field. Dr. Vadiraj also did wonderful work on cancer when they were here with the HCG, Healthcare Global, and it has started spreading into all cancer hospitals as an adjunct. And this is what we want today, that it should spread everywhere, and we should take up this cancer studies much more in a bigger way. If we can get good funding, if the Ayush can allot some good funding for this thing, we can replicate what we have done there in United States, and even better, we can do that here in India, and it can be a multi-centric trial. We can do that. That will bring the efficacy of yoga as an adjunct throughout the country. Therefore, on this very auspicious day, I congratulate Vikram Singh ji, Rajesh Koteja ji, and the Minister of Ayush for organizing today's program under the banner of CCRVN. Thank you all. Namaste, Raghavendra ji, and Ansuya ji, and all of you, and all the people who have joined from various Ayush institutions and other. Namaskar.
Thank you, Guruji. And now I have with me Sri Vikram Singh Ji, who is the Director at the Ministry of Ayush. He is representing the ministry today, and we have a very good team in the ministry under his leadership, under the leadership of our Joint Secretary, Mrs. Kavita Garg as well, and also our Dynamic Secretary, Sri Vaidya Rajesh Kotecha Ji. So on behalf of all of them, we have a very dynamic representative, Sri Vikram Singh Ji, who is a very ardent follower of yoga and naturopathy. He himself is a naturopath, I can say, and he believes not just believes, he also practices naturopathy and yoga. So I invite upon Sri Vikram Singh Ji to encourage us and encourage the team here in CCR1 as well as the audience who are there from all across the country for a few words of encouragement from you is requested, sir. Thank you.
Thank you. Namaskar, respected Guruji, Dr. H.R. Nagendraji, Professor Bhushan Patwarzanji, Dr. Raghavendra Rao, and Dr. Anushuria, and others, those who are connected through the web. I am representing, Secretary Ayush, who was supposed to be the chief guest, of course, and I convey best wishes on behalf of Secretary Ayush to this webinar. कभी धूप दें कभी बदलियां दोनों दिलो जान से दोनों कबूल है मगर उस शहर में ना कैद दे जहां जिंदगी की हवा ना हो. We all know that chemical, physical, biological agents, etc. cause cancer. The first encounter of this word cancer I met was, lymphosarcoma of the intestine. And we all know that it was part of one movie called Anand, starring Rajesh Khanna and Amitabh Bachchan. This film was made in 1971. We must have seen this film. And we have seen the emotional and psychological things in the film. However, in real life, the psychological emotional issues are much different and distant. Now, after 50 years, we realize that the majority of such cases are curable if detected in time. As Dr. Patwarzanji and Guruji also told, that cancer is one of the, or the second leading cause of death after heart disease. At global level, I think India has the highest number of oral cancer cases. Tobacco perhaps is the biggest cause of cancer in India. The high rates of cervical and breast cancers have created a higher cancer burden in women than men. And we have to take this challenge. I'm happy to note that this webinar will cover psychological, emotional, and palliative care issues. One session on role of yoga in cancer management is also planned. I hope there will be good deliberations in the webinar and wish that a summary of the deliberations and discussions are and actionable points are forwarded to the ministry for any intervention. Please also suggest more how yoga and Ayush intervention methods can prevent a number of cancer cases from taking a serious stage and how they can be implemented. Because as Guruji told, the issue is to implement now. And at the ministry, we have the best team and we all support. As Galib Saab has said, ये कहाँ की दोस्ती है कि दोस्त बने हैं ना से कोई चारा साज होता कोई गम गुसार होता. Yes, I can assure you on behalf of Ministry of Ayush that ministry extends wholehearted support to the measures in detection, prevention, cure, and research of cancer. I wish a great success to this webinar. Thank you very much.
Thank you, Sri Vikram Singh Ji, and thank you for your words of encouragement and support from the ministry to the CCR1. And CCR1 is already involved in a lot of work in this area. We have now started the Center for Mind-Body Interventions through yoga, and some of the research projects which are also come up in the area of cancer. So we are working on various aspects of yoga and myofascial pain in breast cancer patients post-surgery. And we're also working on use of yoga interventions in pain management as well. So in the next 3 hours, without much ado, I would like to invite the speakers who are here in the first session. Okay. So before I do that, I would like to give my concluding vote of thanks to all the people who came for the inaugural session. My heartful thanks to Bhushan Patwarzanji, Dr. H.R. Nagendra, and Shri Vikram Singhji for being here with us for this inaugural session. And now we are coming to the end of this inaugural session. I thank them wholeheartedly for their support. And we have some experts in various fields of oncology now. So in the next 3 hours, we have people from the psycho-oncologists we have palliative care specialists, we have medical oncologists, and we also have yoga therapists who are also here, who are stalwarts in their own area, and who also done a lot of work in the area of integrating yoga in oncology in one way or the other. So we'll be hearing from these experts in the next 3 hours. And the first session will be by the psychosocial issues on cancer, okay, and symptom burden and psychosocial issues in cancer. And the speakers are Dr. Jayita Diodar, who is, and as well as Dr. Suchitra Mehta. So I request Dr. Anusuya to introduce the speakers.
Yes, sir. Thank you, sir. So I welcome you all for the first session of the seminar on the topic symptom burden and psychological issues in cancer patients. And we have with us Dr. Suchitra Mehta, who is a psycho-oncologist, HCG from Nagpur, and Dr. Jayita Diodar, Department of Palliative Medicine, Tata Memorial Hospital. So first of all, I'll introduce Dr. Suchitra Mehta. Dr. Suchitra Mehta is a director and head of psycho-oncology at HCG from Nagpur. She has presented numerous papers in various national and international psycho-oncology conferences, which is held at Australia, Turkey, Portugal, Ireland, and Canada. She has a special inclination towards a research in psycho-oncology. She has designed a psychosocial assessment form incorporating distress thermometer for regular use at HCG Nagpur. She has also arranged various rehabilitation programs for cancer survivors in the form of exhibitions, fairs, walkathons, and fashion shows by cancer survivors. She's also actively involved in preventive oncology programs, conducting cancer awareness lectures and camps, running tobacco de-addiction programs as well. She has authored a book looking inside the minds of cancer patients and CBT in 2017. And along with Dr. Suchitra, we have with us Dr. Jayita Diodar. Dr. Jayita Diodar is a professor, Department of Palliative Medicine in Tata Memorial Hospital. Her clinical and research interests are psychosocial interventions in cancer patients, psychosocial palliative care, early palliative care, and quality improvement. She has various research publications and presentations in national and international conference. So for this first session, this session will be moderated by the director of CCRN, Dr. Raghavendra Rao, who holds a PhD in Yoga and Life Sciences from SVS's Swami Vivekananda Yoga Anusandhana Samsthan University. He was a senior scientist and head Complementary and Alternative Medicine in Healthcare Global Enterprise Limited before joining in CCRN. He has contributed much in the oncology as well. So he has completed several research projects in rheumatoid arthritis, pre-diabetes and diabetes, cardiovascular risk prevention, and has over 89 international research publications. He has also won several awards such as Manomay Rudraya Award and ASCO Conquer Cancer Foundation Merit Award by American Society of Clinical Oncology. Now I request the director to take over the session and welcome our speakers, Dr. Suchitra Mehta and Dr. Jayita, to please switch on your audios and unmute yourself, please.
Thank you, Dr. Anusuya. Thank you. Now I call upon Dr. Jayita Diodar, who is head of palliative medicine at Tata Memorial Hospital, to begin her talk. Over to you, madam.
Hello, good morning to respected dignitaries. I sincerely thank Dr. Raghavendra and Dr. Anusuya and the whole team for inviting me to be part of this fantastic endeavor on the occasion of World Cancer Day. And I know that you have always done it every year with due diligence, and that evokes a lot of encouragement and passion for all of us who are working in the area of oncology and palliative care. As I shared with you earlier, that I do not really have a formal presentation, but there are just certain points that I would like to focus on, and then we can I can take up questions or discussions by when Dr. Raghavendra asks me. So as as our respected Guruji, Dr. Nagendra ji have said, and Dr. Raghavendra has said, I think they have said that there is, it's not just physical. Physical is always going to be entwined with the psychological issues. And cancer, any point of from the screening to the diagnosis to undergoing treatment to maybe recurrence or go into the path of survivorship or palliative care. There isn't any point in that just that physical is going to be our focus. And it's obviously going to be psychological issues which can vary from day-to-day stresses to adjustment disorders, to depressive anxiety symptoms, or even going on to having a clinical diagnosable psychiatric disorders. And the underlying importance of this is associated with suffering. So if there is a physical symptom that will cause suffering in any of these domains, psychological, social, practical, financial, spiritual, existential, and that suffering may worsen the physical symptoms. So it is very important to take care of all the domains for a person-centric approach. That is how the whole field and discipline of psycho-oncology developed. That is what Jimmy Holland said, that it is the human side of cancer. The other point I would like to make is that we have a program for identifying issues, and at the same time we have to think about interventions. And so there are various evidence-based interventions that can happen for these, can be taking place for all these psychosocial issues that we have. We have to very much focus on our indigenous interventions that we have, and of which the prime importance is, of course, yoga. So the randomized controlled trials that have been done have just given the importance and the emphasis, and we need to focus on that in our regular clinical practice. In our practice in research and practice in Tata Memorial Hospital, our director, Tata Memorial Center, Dr. Badwe, and his team, we and me as part of that are doing a randomized control trial with yoga and conventional exercises versus conventional exercises in breast cancer patients. It is 2 arms with 425 patients in each arm. We have finished recruiting now, and the ongoing evaluations are going on. So that is as part of research that we think that yoga is very important. The second is that in our psycho-oncology clinic and practice, yoga and principles of yoga, and even in palliative medicine, we have somebody with a structured instructor, specific instructor in yoga. So those principles and practices, relaxation training, breath, meditation, all these are areas of focus in our daily clinical practice. And I can say from my practice and our practice that not a single patient would come to the clinic whom we would not talk about the benefits of yoga and what small things can be done, and later on that they can go on to individual program depending on the on their situation. And we do have, as part of the study, we have yoga instructors coming into the hospital on a weekly basis on our sessions, because everybody is in different phases and they are given a set of asanas and breathing exercises and pranayam that are done. And having been part of that research, I inculcate that in my regular clinical practice. The third thing I would like to say is it's not just the cancer patients that are in our purview. it's also about the caregivers. Because as we know, no man is an island. We live in a system of the family. So one part of the system, if somebody is affected, the rest of the system is also affected. So what we practice for the patients, we need to be very mindful also of the caregivers and give different sort of interventions, understand their distress as well, and different interventions for the caregivers. This is for the family caregivers. It is again not complete without us talking about the professional caregivers. That is all the healthcare workers working in oncology and palliative care, because we need to look after the people who look after the patients, and that also involves self-care. So these are the 4 different points that I wanted to highlight in the context of this panel discussion. Thank you again for giving me the opportunity to speak, and I am very much here for the next hour for answering questions. Thank you so much.
Thank you, Dr. Jayata, and it is interesting to hear from you again. And over to Dr. Suchitra Mehta from Nclpur, Nagpur. And she's been a very ardent follower of yoga herself, and she also uses music therapy, art therapy, etc. for cancer patients. And over to you, Dr. Suchitra Mehta. Madam, are you audio? Yeah. Madam, you need to unmute yourself. Madam, you should unmute yourself. I think she is logged into 3 different devices.
What she was saying, she was not able to see that logo actually. What she was saying is.
Is she not able to log in?
Yes. No, she has logged in, but the thing is she was not able to see that screen of that. 1 second, ma'am is calling. Hello, ma'am.
I'm sure she can share only through her laptop presentation. She can't do through her phone.
Okay. Yes, I told her. She said she's doing it actually. She's not able to connect it actually. That's the thing.
She has connectivity issues, huh?
Yes, sir.
Okay. While she has some connectivity issues, I would like to be posing some questions for Dr. Jayata. And Dr. Jayata, until such time does Dr. Suchitra could log in, let us not waste some time. So let us make use of the time you're here. And I would like to ask some questions to you. What symptoms are most common in cancer patients? Because you see a lot of patients who come to your center, especially in TMH, and you see a lot of patients who come to your palliative care medicine who are referred by the oncologists for symptom management. So what are the symptoms which are more common in cancer patients which you see today?
Thank you, Dr. Raghavendra. In my experience, the commonest symptoms are anxiety symptoms rather than an anxiety disorder, although generalized anxiety disorder can happen quite commonly as well. The other common symptoms are fatigue, which we need to relate to understand why the fatigue is there. Is that physical, or is it related to depression or anxiety? And the third common symptom is our sleep disturbances. Which you can understand that because of your the physical symptom profile, undergoing treatment, coming from various factors, coming from different areas for treatment. So these are the common sort of symptoms. Apart from the social and practical financial problems that patients face, and those will actually aggravate these kind of psychological and physical symptoms.
Thank you. And do you think these symptoms have the attention of the doctors and oncologists, and how much of these symptoms are really managed during the course of treatment?
That's a very valid point. I think especially in our institute, because of the sheer number and the volume load that we have, the oncologists are really quite emphasizing on their oncology treatments. To be fair to them, they do pick up the symptoms of which are bothersome to the patient, and they would refer. But of course, 100 patients going through their OPDs every day, everybody, it's very difficult to identify. So they do refer, but we work in a system called with a disease management group. So we have head neck cancer, we have breast cancer, we have hematolymphoid, adult hematolymphoid groups. So what we have done is, as part of, we started as research, but we continue as a clinical practice, is doing some kind of screening when the patients are coming, mostly by using the distress thermometer, and even in sort of radiation therapy settings also, or gynecological oncology we just done, and it's ongoing now. So we've started, some bits are started as research, but it has now gone into implementation mode as practice. So that is how the frontline workers, especially the nurses can identify and can then refer to us. So, but even if they are, even if the oncologists are busy, they are quite mindful of these issues, and the referrals to psycho-oncology and palliative medicine do happen. And especially in palliative medicine, a lot of our referrals now are for early palliative care, in which then the comprehensive assessment is done.
Thank you, Dr. Jaita. And there's one more question. While Suchitra is trying to log in, she has some issues in connecting her presentation. I think she's now coming in. Namaskar, madam. We can see you, ma'am.
Okay, thank you very much.
Yeah, you're now audible as well.
Sorry.
Not at all, ma'am. Ma'am, can you share the presentation?
Yes.
Yeah.
So first of all, good morning, everyone, and sorry for this delay. And thank you, CCR Wine, for arranging such a beautiful and very relevant program. So I'll start my presentation. Yeah. So are you able to see?
Yes, ma'am.
Okay.
We can go to the slide mode. Yeah, fine.
Yeah. So today I'm going to talk about symptom burden in cancer patients. So let us hear a story first. Once upon a time, there was a man who was very drunk, and he was not able to walk properly. He was swagging, and he was not in his senses. A common man saw him, and he said that he is such an indecent, immoral, and we should all stay away from him. Then came a physician. He said he is a case of substance abuse. This looks very disoriented, and soon he will develop liver cirrhosis and need treatment for that. Police came and they wanted to catch him and wanted to put him behind bars. Then came lawyers and the court session started and they wanted to announce the verdict. A psychologist was standing there and he said, "Hey, wait, let me take him to a comfortable place and let me listen to him. Let us hear him out. Let us hear his story, what he wants to talk. Let us understand his issues so that we can help him out to come out of this situation." So whatever may be the situation, whatever may be the disease, there will always be some distress related to that. So it can be physical, it can be emotional, it can be psychological, but symptoms due to distress will always be there related to that particular situation or particular disease, whether it is cancer or non-cancer. So distress is now taken as the sixth vital sign by all the stakeholders who are they understand that that distress should be taken as sixth vital sign while we are talking about cancer management. So according to NCCN, what is distress? It is nothing but a multifactorial, unpleasant emotional experience that can be psychological, social, or spiritual in nature. And that affects a lot in the ability when the patient is coping with cancer and the related problems. So this needs to be addressed. This needs to be tackled and this needs to be managed. So when we talk about common symptoms of cancer patients, there are mainly disease related, that is medical problems like there will be lump or pain and fatigue, and system related like vomiting, loose motions and all that. There will be weight loss and sleep disturbances. But along with that, there will be psychological, social, and emotional issues also that will cause a lot of distress, like fear, worries, anxiety, depressive symptoms, sadness. There can be emotional outbursts like anger, frustration, hopelessness, helplessness. Then there could be social issues like family-related, job-related, and financial problems. And there could be spiritual issues also. So when we talk about cancer management as a whole, we understand that in addition to surgical oncology, medical oncology, and radiation oncology, psycho-oncology also needs to be included when we talk about the comprehensive cancer management. And in psycho-oncology, there are various aspects of psycho-oncology, like there is preventive oncology, there is psychotherapy, then there is support. There are various supportive therapies. There is diet therapy. There is physiotherapy. Then yoga therapy. So there is rehabilitation. So all these things are included in psycho-oncology. So at SCG, we have designed this form, psycho-oncology assessment form, in which we get all the, this is to know the distress, this is to know the psychosocial issues which are there in the patient. And let me tell you that in our hospital, we have seen that in fact, in anywhere in India, if you see in any cancer hospital, patients, they don't come on their own to consult a psycho-oncologist, and they are not aware that such type of help, such type of support is there for them. They feel that when they are diagnosed with cancer, they need to be treated, and that is true. They need to be treated and they need to be managed, but they need to be managed as a whole. So in our assessment form, we collect demographics, and then type and stage of cancer is very important because that reflects to more distress, as the stage advances, distress level gets more and more in severity. Comorbidities are very important because, as you all know, that diabetes and hypertension are number one and number two in when you talk about comorbidities in India. So, and when we talk about managing distress, we need to consider these comorbidities because we need to direct the patient to take care of these comorbidities also. Then awareness about cancer is very, very important because in India, again, this is lacking, and we need to make them aware about the preventive things. We need to make them aware about the cancer as such, why it is caused, and sometimes they feel that it is their fault. They feel guilty, and there is a lot of emotional outburst. So all these things can be related to less awareness or no awareness about cancer at all. Then family history and other things are very important. We asked them about addictions. Addictions, as it was told by previous speaker, that tobacco is number one in India, tobacco chewing, and in this, especially in this part of the this part of India, central India, tobacco chewing is number one. Actually, this part of central India is number one in tobacco-related oral cancers all over the world. This is number one. So we give a lot of importance to addiction, and it has seen that they have a lot of guilt when they develop cancer. They have a lot of guilt, and they have more distress because it is caused due to their addiction. Then we ask about fitness awareness, diet, and sleep, because all these things they are related to immunity, and we know that immunity and cancer they go. I mean, they don't work together. So we need to ask all these things and give and manage the patient accordingly. Then we ask about their quality of life and level of fatigue. So all these symptoms, if we assess, then it is it's a proper way to manage the cancer patient as a whole. So most important thing here is distress thermometer, which is designed by NCCN. And this is the basic distress thermometer, which is designed and needs to be followed by each and every cancer hospital who are into cancer management. And we have modified this this questionnaire, and the issues which are put in the main distress thermometer, we have modified them a bit according to Indian setting. So there are a lot of things like practical issues, emotional issues, physical issues, family issues, spiritual issues, and according to that we assess the distress level. And there are other instruments also, but all instruments they need time. And as I told you before, that our patients in India, they feel that as soon as they are diagnosed with cancer, they need to start their treatment at the earliest. So they just don't wait. So it is very difficult for us to counsel them for psycho-oncological support. And only when we are doing some research or we are doing some studies, we are using these instruments or we are using these scales, not otherwise, not on routine basis. So when we talk about management, let me tell you that it is very important to discuss that case with the treating doctor. And if the treating doctor is not available to discuss, Then we refer the notes to see actual notes, what has happened to the patient. And then we do general counseling by psycho-oncologist after initial assessment. And then we give problem-specific counseling and referral. Like sometimes, as I told you that it is, they have comorbidities like hypertension, diabetes and all that. Then we need to give them lifestyle modification counseling, like diet, physiotherapy. And many patients here are referred to yoga therapy. In OPD, we are not following for each and every patient, but yes, for indoor patients, those who are admitted and those who are taking treatment, we are giving yoga therapy, yoga consultation, yoga counseling to each and every patient. And after that, we do follow-up. We do rehabilitation and we engage them in support groups. We have various support groups like breast cancer support group and support group for women cancer, for pediatric patients. So all these things, they constitute a major part of psycho-oncology. So this is the World Cancer Day today, and the theme of this Cancer Day is very good. That is close the care gap, and this is very relevant to our department, our therapy. We really need to create more awareness about cancer and make them aware that this type of therapy, this type of care, this type of support is also available in addition to just the treatment, medical treatment. So we need to emphasize on primary and secondary prevention, lifestyle changes, and treatment. Each treatment should include psychosocial and emotional care. So this was in short about the symptoms and the psychosocial care. So if you have any questions or if you want to discuss anything, I'm ready here to answer the questions.
Thank you, Dr. Suchitra. Ma'am, it was a very interesting talk, and you just showed the workings of the psycho-oncology department, which you have been heading in your hospital, and how these things are documented for patients. And this is very important that we also have to document a distress thermometer. So the question to you is, apart from distress thermometer, do you think any other instrument can be used for triaging patients based on the distress? For example, I had been to Memorial Sloan Kettering Cancer Center as well as Banner Health Foundation as well. So in US, they use PHQ-9 as one of the scoring instruments for any sort of psychological interventions for psycho-oncologists. So do you think that can also be adapted to Indian settings?
Dr. Rao, there are various validated scales and instruments, and they are routinely used outside India by many hospitals. But when we talk about Indian patients, it is very difficult. As I told you, that the first thing is that they are not aware about this psychosocial support. And when we ask them, I mean, when our front office asks them, do you need any psychosocial counseling, psycho-oncology consultation, they straight away refuse. So leave this assessment and everything, because everything will need time. And when the patient comes to us, they want to start the treatment as early as possible. So we stick to the basic thing, like we do psychosocial assessment with that form. And because that gives us almost major idea about the patient. And then we routinely use the distress thermometer. So these two things we routinely use.
Yeah, thank you, ma'am. So you said a very important point here, that people are not really aware of the psychosocial interventions of psycho-oncology. And there's also a social taboo attached to it that something to do with psychology means there's something wrong with them itself. So that's the reason why they really don't accept this fact or are not so really keen on getting a intervention. So just to touch that small point, there was a small, there's a very big concept called Dabda Effect, which was proponed by Kubler-Ross, who was a very great hospice nurse who passed away in 2004. And this is where this talks about the trajectory of the cancer patients, how they react to the diagnosis of cancer and the treatment of cancer, and how do they cope with it psychologically over time. So could you just throw some light on this Dabda effect?
See, we know that all these research things and whatever the studies say, but when it comes to practical, because I'm more into research and I have been using all these things, I have been lecturing about all these things, but when it comes to practical things, then we need to go case by case. Like we don't know how the patient will react like this, that there will be denial first, there will be anger, then there will be depression, there will be acceptance and all that. And all these, then there will be like what the emotional outburst of any patient, any cancer patient is very difficult to predict. And so we go case by case, and then we manage the patient accordingly.
Thank you, ma'am. So there is an analogy that most of these patients, when they're going through the cancer treatment, depending on which stage of the disease, even with early stage of disease or later stage of disease, they get in touch with other patients who also have undergone the similar procedures. And there are both positive influences and negative influences. Is there any way the psycho-oncologists really help in advising patients on what should be taken? Because even if the patient has the same kind of breast cancer, the trajectory or course of the breast cancer in the one patient is entirely different for the same stage and type compared to other patient as well. So is there anything which psycho-oncologists also do to bring this awareness on about this concept in cancer patients?
Yeah, we have done very interesting study in this, because especially when you're talking about the treatment, people, they get a lot of time and they are waiting for a lot of time in the hospital. They are undergoing radiation therapy. So in these patients, we have done few studies, and we have a yoga therapist at our center. She has done study on mindfulness-based meditation in these patients, so that they are engaged in some good activity, and they are not affected by other negative thoughts or negative surroundings or any other patient's negative story. And another thing is that we have done another study on breast cancer patients, that is mindfulness-based art therapy. So we have inculcated art therapy. We asked them to color the art, and that was after the 15 minutes of mindfulness meditation. So these type of activities, if we engage them for these type of activities, they help a lot.
Thank you, ma'am. Now the question is to Dr. Jayita. What kind of psychosocial interventions are feasible in clinical settings?
Yes, that's an important question. As Dr. Suchitra said, that we have to sort of think about what is going to be more practical. So in my experience, what has helped and what does help is the basic tenets of counseling. So client-centered counseling is going to be there. That is the underpinning of all psychological, psychosocial interventions anyway. because patients are anxious. So anxiety management techniques and relaxation exercises and mindfulness-based exercises, we can tell them, that helps. Just telling them about yoga, or if they have had some experience with yoga before. What really helps is also, although we don't talk about it, but the educational intervention or psychoeducational interventions, like these concepts that Dr. Suchitra was talking about, listening to other people, information about that. Lots of people don't even know what the exact diagnosis is, what the treatment plan is. So just giving a basic forum to discuss such things helps them to allay their anxiety quite a lot. And the fourth one that I commonly see, because those are the common issues about sleep disturbances and insomnia. So then education, psychoeducation, and sleep hygiene. These are sort of practical things that we can do how much ever time we have. We don't need a lot of 45-minute session for that, but these sort of snippets of information and a basic structure which we can do. The other thing that is very practical is a structured routine, because people are living such a chaotic life, from the time that they were diagnosed, between where they were before and what they are now. It's all a whole mix up of when to come for chemotherapy, daycare appointments, go for the blood test, come back for the radiation scheduled for that. It's important to have a structured routine, plan for when they are in hospital and plan for when they are at home. So that regularizes for this helps in their sleep schedule as well, because when they are inpatients, obviously the sleep patterns are going to be very disrupted. That's a different thing when they come for outpatients. So a lot of things can be done on a practical day-to-day basis. What also helps, although research is full of cognitive behavioral therapy, etc., for cancer patients and survivors, what I find useful is approaches, cognitive behavior therapy approaches. So people are having practical problems. So the problem solving approach does help. And when especially in palliative medicine, a lot of it is about listening. So in that listening, that just comes under the client center, but it also comes under meaning-making therapies, because especially during advanced illness, when expected survival is limited, a lot of it is about meaning making. Although these sort of concepts have come from West world, but we know in our sort of culture and context, whatever religion, whatever spirituality it is, we want to find out that meaning and purpose in life. So in the context of talking to the patient and the caregiver, a lot of sort of meaning making processing goes on in their minds. And even if we have that one session with them, at least we start them thinking about this, and then they can, even if we don't meet them, we don't have the privilege of meeting them again, maybe some things that they can do. Because in cancer, for cancer patients and cancer survivors, self-management strategies are very important. So then we can as our clinical practice, we can help them by that. The last one is about support groups, because support groups is about learning from each other. And that as part of the support group, educational interventions also come in, information provision. So a lot of these myths and misconceptions then can be addressed, because the support groups usually have the oncologist as well as the psycho-oncologist and the volunteers. So a lot of the misconceptions can be addressed at that stage. Thank you.
Thank you, Dr. Jaita. And there are some questions also. I think some people have raised their hands. So I would just request those who raised their hands to put in their questions in the Q&A box. So we'll ask these questions to the speakers once you put these questions in the Q&A box. So kindly type your questions in your Q&A box so that we can ask the questions on your behalf. So here there's a question from Ben from Jakarta. for a blood cancer patient, is it possible to avoid chemotherapy? Just do yoga, that is asana, pranayama, and meditation, and Ayurveda. Thank you and namaste. This is a question from Jakarta. Dr. Jaita, can you answer this?
Yes, Dr. Raghavendra, I thought you would be the more person to answer that. But so I am in psycho-oncology. I'm a psychiatrist. I am a palliative medicine physician. I work in oncology. So I understand about the emphasis on all the therapies that are there. But with blood cancers, it could be either leukemias or lymphomas. We need some treatment for the disease. We need to treat the disease, because it's not just like we do not exclude the psychosocial, we cannot really exclude the physical. So we need to treat the disease. And along with the disease, all the dimensions need to be addressed. So yoga and therapy can be very good as adjunct treatments, but for the disease management, we do need to consider all the treatments that are available. And that is what is a holistic treatment. So with the disease and the person-centric approaches, both these will be helpful.
And just to add on to you, Dr. Jaita, the cancer is a different entity by itself. It's not like other disease where psychoneuroimmunology alone can really help in combating it. There is an organic form of disease, is a tissue on its own origin. It has a mind of its own. It can create its own blood supply. It's an immortal cell. It allows stress. It allows inflammation, and it allows to thrive as a parasite inside your body. So this has to be removed with conventional means. Along with that, add on adjunct yoga and Ayurveda may really be beneficial, but we require more evidence to really say that only these three measures and Ayush interventions could be useful in the long run. There are anecdotal evidence where we have seen patients taking recourse to those interventions. Some of them do claim to have been cured from cancer, but we require more evidence from these kind of claims. And unless these are proven in proper randomized controlled trials and proper evidence-based research, we really can't claim that these interventions alone can really help in facilitating this. There's another question by one Dr. Naveen. How to improve awareness of psycho-oncology among patients who are really not aware of it? This can go to Suchitra Mehta or Jaita, anybody.
Yeah. Yeah, so this is a very good question, and this is actually my question, how to create awareness among general public about psycho-oncology. But best way is what we practice here is to do cancer awareness. So in cancer awareness, we talk about these things also. Like when we go to various organizations, colleges, and places where we do cancer awareness or we do cancer detection camps. At that time, I give lecture on this, stressing this point too, that this type of care, this type of support is also available. And you should, and as I told you that psycho-oncology is not only managing the psychological, emotional issues of the cancer patient, but it includes preventive oncology also. Preventive oncology, then psychotherapy, and then rehabilitation, and then support groups intervention. So all these things people should, we should try to make people aware of all these things. So when they come to hospital, it is very easy for us to link. But when we want to reach the masses, then we need to do cancer awareness in a different way. Like in addition to just the cancer awareness, the disease awareness, we need to tell about these services also.
Yeah, thank you, madam. And there are a few questions as well. There's one question on breath holding pranayama practices is contraindicated in cancer patients. I would leave this to the third session because we have yoga experts in this session and they will be able to give the answer on this particular topic. Okay, and how to improve oncology. Oncology is already been improved. A lot of things have been happening in oncology sphere, where there are a lot of advancements in oncology, where from basic chemotherapy, we have now moved to immunotherapy, targeted therapy. We have moved to precision-based radiotherapy. We have moved to genomics and personalized medicine, where we are able to delineate patients who are responsive for certain chemotherapy drugs and who are not responsive. And we're able to get better outcomes than before today. And we see a huge advancement with respect to hematological malignancies. And what we see today is that the one area where the advancement in oncology has really happened, which has really helped in reducing mortalities from hematological malignancies, where mortality rates which are very, very high before in the early 90s are now cut down drastically in various types of hematological malignancies with better kinds of treatment and target therapies. So this is one of the questions which somebody asked. So I just answered this. And there is one more important aspect I would just want to touch upon. Is you are because since you are also a palliative care, heading the palliative care department, Dr. Jayita, there are people who come with a lot of symptoms. They must have tried all their efforts in conventional treatment. They might have had a relapse. They might have had a metastatic disease. So they also are. They also take information from the net, from the Google doctor. So many of them come with information from the Google doctor, and how many patients you see kind of this who come and give you an advice on what to be done.
Yeah, that is the that sort of contemporary progress, the price for progress that you have to compete with the Google doctor to give your evidence-based medicine approaches versus Google doctor. So they, of course, they do that. We have to accept it. They are going to do that. We have to accept it. And it needs, because by the time, so the ones, we have different referral patterns. So early palliative care, they know that they are coming here for symptom management as part of early palliative care. It is when suddenly the goal of care changes to best supportive care. That is when the difficulties arise, that people have been doing all the disease-related management and sort of getting the cancer-directed therapies, and then it is changed to best supportive care. It is important to, so the communication preference and communication pattern, communication provision is very important, I feel, in that respect. So if we follow the proper way of breaking bad news and understand their knowledge, what they know already, and then go step by step. And sometimes these are very challenging, does not happen at one session, and people may not still have that acceptance level. So it's not just about grief and loss and Dabda for the cancer patients. It's also about this, that they have the challenges. But if we give them our evidence and tell them about according to what they want to know, and have a sort of collaborative, shared decision-making, shared discussion, I think that helps.
Thank you, ma'am. And I think I do have other questions. Maybe people are talking about there are malignancies diagnosed at third stage, complete deteriorated state by one Satya Soumya. Whether psycho-oncology, yoga helps them. So I think probably they are talking about people with metastatic cancers and who are in a debilitated state with a lot of symptom burden. Do you think these kind of psycho-oncology support as well as yoga can help in these patients?
So for the psycho-oncology support, of course, it will be helping them, because the whole emphasis is person-centered approach. So it is not just enough to deal with the physical symptom management. We have to do good pain and symptom management. That is what good palliative care is. But along with that, especially with an advanced disease, the psychosocial issues become even more prominent, and what become more prominent are these spiritual, existential, and meaning and purpose issues. So I think that that is very important. And if we are talking about, people in debilitated state approaching death, so there's this concept of death anxiety. So, a supportive kind of therapeutic relationship is very, very useful in people with this death anxiety and approaching death. So yes, psycho-oncology support and psychosocial palliative care is an essential component in managing patients with advanced disease.
Yeah, I would also like to add to that in such cases, home care is also very important. Home palliative care especially, and home care, home visit, palliative team is very important, because they can be a good connect. They can act as a good connect between the patient and the doctors and the team, specialist team. So at the end stage, or when the patient is dying or the patient is bedridden, at the time, home care management is very, very relevant.
Thank you, ma'am. I think you had a very long and fruitful session to look at psychosocial issues in cancer patients. This is a very, very important area of concern. Why I say this is because this is often not addressed. So I would just last question to both of you, because both of you are practicing in oncology settings. How much % of patients are really referred for psycho-oncology counseling? And if suppose you have about 4,000 new cases in your hospital every year, how many of those cases really take recourse to psycho-oncology interventions?
So I think where I practice, we really do have, though it is not a very formal levels of care, supportive care as dictated by NICE guidelines, level 1, level 2, level 3, level 4. But we do, somehow it has come into a stepped care approach. So you do have at level 1, the frontline workers, everybody who cares for the patient, including nurses, etc., volunteers. There are many informal counselors in the hospital, and we have a special cadre of healthcare workers now called patient navigators, KWATs, who we are the first one to have done this course in the country. It is the third batch who is coming in now. So they provide, all these people provide the level 1 to level 2 care for the psychosocial care for the patients. It's level 3, level 4. It depends on the setting that you are in. Ideally, we have to, refer everybody who meets that certain criteria. And so screening plays an important role. But the other part of screening is whatever screening programs we take on for psychosocial distress, it has to be balanced by adequate resources. There is no point in just doing the distress and then there's not enough psycho-oncology resources, staff that is available. So it always has to be a balance between the two. So, clearly speaking, not as much as we would want them to be referred to us, but with the levels of care, at least we are there for the ones who need the care most from the psycho-oncology staff, and the others who need a little less are being provided by their healthcare workers who are working with them. That is my hope.
Thank you. This is the last question to the team. Does stress cause cancer? So there's a question come from one of the audience. Does stress cause cancer? Psychological stress.
So Dr. Rao, I would like to add to the initial question which you had asked to both of us regarding how much % of patients they are referred. So in our hospital, if you ask, it is less than 5%. So we have made a system that every patient at least once in their during their treatment or during when they come to the hospital for diagnosis or investigations, once at least once they come to take psycho-oncology, psycho-oncology counseling is done and assessment is done, and then according to the need, we refer them to the specialty. So this is the one question which I wanted to answer. And second thing about stress, there is a lot of research. In fact, I have also done one study, but that was not a randomized control trial, and it was a small study. So so there are relations between how the stress is caused and what changes it makes to our body and cancer development. But as such, it is not scientifically proved so far. So many studies have been conducted, but it is not proven that stress causes cancer.
Just to add on to this, the last one is basically what studies have shown is that stress may not really cause cancer, but what they've really shown is through animal models as well as research in cancer population that people who have psychological distress have higher levels of mortality and higher levels of recurrence and metastasis. So this has been proven through large observational studies and large cohort studies, and but we really don't know whether really stress can really cause cancer at this moment. So thank you all. Thank you for this very vibrant session. It was heartening to hear from two great stalwarts who are working in this area of addressing issues in cancer patients. Thank you, Dr. Jaita, ma'am, and as well as Dr. Suchitra. And what we want to do is, in continuance to this particular session, we also want to start a small program for a certification program for Ayush doctors, basically. So we would want to take the lead in developing such kind of program. We had similar kind of program at HCG a long time back when I was there in HCG there. So we want to do this kind of a program where we would like to enlist hospitals and enlist people like you, experts like you, to help in mentoring the Ayush doctors in delivering a concise program. So probably we'll meet over another conference where the people from different institutes will meet up, and we'll design such a program so that we can help in taking this to a larger audience and larger number of Ayush doctors, so they are made aware of cancer patients' psychosocial issues and how to take care of them. Thank you so much, madam, and thank you for being here. So we go to the next session. Next session is on palliative care issues in cancer patients. Over to Dr. Anusuya to introduce the speakers, please.
Yes, sir. Now it's time to begin our second session to the seminar on the topic palliative care issues in cancer patients. And we have with us today Dr. Anuja Damani. Please switch on your videos, ma'am. Dr. Anuja Damani and Dr. Sushma Patwarzanji, please. And we have with us today Dr. Anuja Damani, who is affiliated to Kasturba Medical College. She is the Associate Professor in the Department of Palliative Medicine and has over 30 research publications. And another speaker with us is Dr. Sushma Patwarzanji, a professor and the head Department of Onco-Anesthesia, Pain and Palliative Care from All India Institute of Medical Sciences, New Delhi. Her research interests are cancer, pain management, and palliative care and onco-anesthesia. She has organized various national and international workshops in palliative care, and she is the editor of Indian Journal of Palliative Care. She is also the recipient of Award of Excellence in Palliative Medicine amongst SAARC countries at 21st International Conference of Indian Associations of Palliative Care in 2015, among others as well. So now I request Dr. Sushma Patwarzanji and Dr. Anuja to please switch on your cameras, and also request Dr. Raghavendra sir to please continue the session, sir.
Yeah, just a second. I'm trying to reach up Dr. Sushma Patwarzanji. I don't think she's there on the panel.
In between she is, sir. Maybe okay. I'll just.
I'm already here. I'm already here, Dr. Raghavendra.
Yes, that's what I've seen you. I've seen you, ma'am.
Okay. So thank you so much. And I would first welcome Dr. Sushma Patwarzanji to give a presentation on palliative care issues in oncology. Ma'am, over to you, ma'am.
me and Anuja have decided that Anuja will do the presentation, but I will set up the stage. Huh? So,
Sure.
you have said just now in Dr. Jayata's and Dr. Suchitra's session that in cancer, we have done a lot of advancement. And we have nanotechnology, molecular biology, and new molecules are coming every day. And so many advancements are happening. Similarly, in medicine, which is a rapidly progressing science, so many advancements are happening. When we were doing our MBBS and when we were doing our MD, nobody has taught us that except diagnosis and treatment, there is something else. So that is why what we have learned that if a patient, any patient, whether we say acute illness or a chronic illness, any patient who is suffering with any sort of illness, we have to diagnose the disease with a lot of investigations, and we have to treat the disease. And if treatment of the disease, cure is not possible, keep on treating the disease. Keep on treating the disease till the time patient will say goodbye to you. So this should not happen. What exactly we should do? So our medical science or the science which you are teaching in Ayurveda or everywhere, it has to go beyond that. When cure is not possible, how to take care of the patient, and simultaneously how to take care of the patient with other aspects, because this is also in our curriculum. This is also a default curriculum, that in curriculum we are learning only to treat the disease, but when we forget, when we are treating a disease, there is a human being whom we are treating. So there are always crisis, and what is the most important crisis? That is informational crisis. So right from the beginning, there are many things which patient wants to know, patient wants to understand. Everything we will discuss in this lecture. So what we will do, Dr. Anuja will explain you everything about palliative care, and then we will, I will summarize, and then we will take up the question answer. So go ahead, Anuja.
Thank you, ma'am. So as we've already introduced the session, so let me talk a bit about palliative care and some evidences about role of integrative oncology in palliative care in cancer. So what are we going to see in this session is 4 objectives that we'll cover in around next 20-25 minutes. That is, what is palliative care? When do we start palliative care? And what are common symptoms that a cancer patient comes across? And what is the current evidence of integrative oncology in cancer palliative care? So coming to our first 2 objectives, what exactly does pallia mean? So palliative comes from a word called pallium, which actually means a cloak or an outer garment. In healthcare, what we use palliative care as a term is to lessen the severity of symptoms of illness without curing or removing the underlying cause. It can run along with the curative treatment, and we'll at the same time try to comfort the patient, try to give symptom management and reduce the severity of suffering as far as possible. So in nutshell, first is to remember that palliative care treats, prevents or relieves the symptoms of a serious progressive illness with emphasis on reducing suffering. Now, why do we need palliative care? As we compare to the pre-antibiotic era, that is around 100 years ago from now, we had people who were dying earlier mostly due to infections. And after the progress in healthcare and after the progress of science, we see that people are living longer. People are living with multiple diseases, multiple illnesses, and one of them is cancer. So hence, people are living longer and people are also symptomatic for more duration of time. They are suffering for longer period of time. And that's why we need to address that suffering along with treatment of cancer. Now, who receives palliative care? It is for patients, and not only patients, but also their families and caregivers who are suffering along with the patients. So it is for patients as well as their families. And what is more important is we also consider patients and families' values while helping guide their medical care. So we may use some of these sentences to understand what patient and families really want, what are their values, and whether their medical care is going in synchronization with their values and their expectations. Now, second question was when to start palliative care. Is it only end of life, or is it only at the end where curative treatment stops and palliative treatment starts? No, actually, the concept of palliative care has changed and evolved over a period of time. So it starts right at the beginning of diagnosis, and the inputs may vary throughout the course of illness, and it goes hand in hand along with the anti-cancer treatment. Eventually, when the anti-cancer treatment stops, palliative care still goes on along with the end-of-life care and symptom management, and beyond death in form of bereavement care for the family. So, other important point to remember from this presentation is palliative care goes along with curative care, and beyond curative care, it will go along till the end of patient's life, and also beyond that to the families in form of bereavement care. So in a nutshell, it aims to improve quality of life of patients and their families. It is for patients who are facing serious illnesses, for instance, cancer. It is not only for the patients, it is as well as for the patient's family and friends, and it can be provided at any time throughout the course of illness. Now, how is palliative care provided and where is it provided? So it is provided by healthcare teams in hospitals. It can be provided in OPD basis as consultations. It can be provided in hospices or long-term care centers, and it can be provided in patients' homes as well. So the core team would consist of doctors, nurses, social workers, chaplains, and allied healthcare professionals. So it is never a one-person input. It is always a team effort. Now, palliative care provides, so what are the inputs of palliative care in healthcare systems? So it provides time for family meetings, time for patients and family counseling, and it coordinates the interdisciplinary meetings to discuss more about prognosis, treatment options, and patient values, and establishing goals of care accordingly. Palliative care provides an expertise in management of physical as well as emotional symptoms of patients. It supports in resolving conflicts both amongst the healthcare professionals as well as patients and their family members. So multiple stakeholders and palliative care can coordinate this. It can play a role in conflict resolving and coordinate goals of care and plan for advanced directives. It also plans for whether the patient should go for a resuscitation or not, depending on the family inputs as well as patient inputs and inputs from the treating team. It coordinates the care across different healthcare settings. So it's not only limited to hospitals, it goes beyond the hospitals. It is also in the nursing homes. We liaise with the physicians who are treating patients at different healthcare points and even at home, and we coordinate the care accordingly. So there are multiple terms you will come across: palliative care, hospice care, pain management, end of life care. So are these terms similar or they are different? So they are different. So what exactly hospice care means? So hospice is a place for people with limited life expectancy. Usually in Western countries, because of insurance benefits, they have a criteria for hospice admissions. So hospice is for those patients whom the doctor prognosticates that they will be living for last 6 months of their life. So it is the criteria for hospice admission, but not necessarily similar thing can happen in our setup. But hospice is basically a place where the curative treatment part has stopped and the patient would actually be on supportive management and would need much more intense supportive management at the end of their lives. So to be very precise, palliative care is a broader term. End of life care and terminal care, pain management is very much a part of palliative care. But palliative care overall starts right at the diagnosis, goes hand in hand along with the curative treatment. So end of life care is a part and not only entirety of palliative care. Now let's move on to our third objective, that is what are the common issues that palliative care patients may face. So they may face issues with diagnosis. So they may face issues with prognosis or prognostication and management of disease in itself. They may face issues of pain, dyspnea, other symptoms like constipation, nausea, vomiting, xerostomia, or mucositis. So these are some of the very common symptoms that we come across. Wound management. So it may affect their functioning, it may affect their bodily systems, it may affect their nutrition, and thus it may also affect their tolerance or response to the disease treatment. So it's important to address physical symptoms. You've all seen about psychological issues in your first session. So there are multiple psychological issues that needs to be addressed. There are issues, social issues, which in terms of change in family dynamics, in terms of finances, in terms of legal aspects. So those are the issues that also need to be addressed. There are spiritual issues, practical issues like caregiving or coordinating the teamwork, end of life care management, and loss or grief management. So these are some of the multiple issues around palliative care patients that need to be addressed to reduce the overall, to address the overall purpose of our healthcare system, that is to reduce the distress of a patient. So palliative care is basically patient-centered. It is death accepting, but also life enhancing. It is a partnership between the patient and carer concerned with healing rather than curing. So healing here actually means about the right relationship with self, others, environment, and the Almighty. So addressing the spiritual distress is equally important. And as it is said that you can't die cured, but you can die healed. So that is what palliative care helps patient to do. That is to die healed. That is to give them a chance to say they love somebody, give them a chance to say, to ask for forgiveness or to forgive people they want to forgive, to say thank yous and their goodbyes when while they are alive. So so let's move on how our integrative oncology can actually help go hand in hand along with the palliative care measures. So integrative oncology basically means use of complementary or integrative therapies along with conventional medicine to treat patient's body, mind, and spirit. Therapies can help with goal of to achieve goals of treatment, to reduce the side effects of treatment, to address the distress, and to improve the treatment results and adherence to treatment. So integrative therapies are various mind and body methods like mindfulness, biofeedback, yoga, music therapy, biologically based practices like adding vitamins, herbs, food, and special diets, body-based practices like massage, and energy medicines like therapeutic touch or Reiki, and other systems like Chinese medicine, acupuncture, homeopathy, naturopathy. So these are some of the integrative therapeutic approaches that can be used for symptom relief. So when we talk about symptom reliefs, what is the current evidence of integrative oncology in palliative care? So the evidence which is strongest is for anxiety, depression, and mood elevation or stress management, which you have discussed in your previous session. Coming to other symptoms, we've seen benefits of various integrative approaches like energy conservative techniques and yoga in fatigue management. Acupuncture and some herbs like ginseng may also help in fatigue management, but the evidence is mild. or in sleep, again, as Joyita ma'am already mentioned in previous discussion, that there are various techniques for improving sleep, and that can be used. Even yoga has some evidence in sleep management. Quality of life and overall physical functioning, meditation has got a very strong evidence for management of quality of life. Other evidences are for acupuncture, guided imagery, yoga, reflexology, and stress management techniques. Some other symptoms, very strong evidence is for acupuncture and acupressure in management of chemotherapy-induced nausea and vomiting. And for pain management, we have evidences for energy and sleep enhancement techniques, massage, music therapy, hypnosis, acupuncture. And there are other symptoms like hot flashes or mucositis and xerostomia, which has got some evidence of integrative oncology techniques. So to summarize, palliative care maximizes quality of life. It manages pain and symptoms. It helps in communication amongst the treating physician and also patient and their families. It coordinates care of medical and supportive care services. It helps in assistance with patient decision making about care. It supports the caregivers and patients, and it is delivered by a team which very much includes the team which handles or which provides integrative therapies. So I would end this presentation by saying the words which were, or reiterating the words which were said by Dame Cicely Saunders, who is a pioneer in modern hospice movement. She said that you matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also to make you live until you die. Thank you very much.
Thank you, Anuja. Thank you very much. Now you can stop sharing so we can see people, so that we can, yeah, very good. Okay. So, see, Anuja has explained you that, see, as a doctor or as a healthcare providers, it is important to look after a person, not a patient. And it is also to, whenever a person is suffering with any sort of illness, I don't consider it in a chronic illness, but even in an acute illness, the family members are also affected. But especially in chronic illness, long lasting chronic illness, family members are severely affected by the disease progression or because of the various other aspects. And most of the time, what we have seen, that family members can be satisfied, we have to satisfy, and we have to make them understand about two things they want to know from us healthcare providers when a person is in their advanced stage, that what is happening to the patient and what is realistic hope possible of the treatment. So when treatment realistic hope is not there, it is better to explain them that we are doing our best. We don't have to leave this patient, but when there is a disease is progressing, disease is becoming violent, that time patient needs intractable symptom management. So intractable symptom management need to be learned, that how to take care of intractable, because you know, when many a time death is inevitable, but nobody wants to die in pain. Nobody wants to die with severe nausea, vomiting, extraordinary fatigue. Nobody wants to die in breathlessness. So what exactly, how can we help them, these patients? How can we help the, how can we help the family members, that they can make a plan? So there is a treatment plan and there will be a care plan. So in both the things, palliative care integration in any of the healthcare system can help to make a holistic or realistic approach to the patient. Anything, any questions? Any questions from this thing? I can see that there are questions.
Madam, I'll just what is the effectiveness of palliative care compared to other treatments? Is it good to compare palliative care with other modes of treatment? Please clarify.
Oh, so palliative care and other modes of treatment, means palliative care is basically providing treatment to relieve the intractable symptom. It is not to treat the disease, but it is to provide the relief from the intractable symptom. So this is basically a treatment. And you know, palliative care physician, or if you will integrate palliative care in any of the healthcare system, you will learn holistic approach. Holistic approach, when a patient is suffering with any sorts of illness, they need, Anuja has shown a very good slide that the disease is one, but there are psychosocial issues, there are spiritual issues, there are existential issues, there is the informational crisis amongst caregivers. You must have seen that caregivers are running around with the thela with all MRI, CT scan from one doctor to another doctor, and they're just thinking that somebody should give them a realistic picture of the disease and realistic hope. We are not saying that we will destroy their hope right from the beginning. There will be hope in the initially. There will be hope to cure. When there will be, then disease will progress. There will be a hope that he should not recur. When there is a recurrence, then there will be a hope that he should not suffer with symptoms. And when symptoms are controlled, they will hope that he should not die with agony and suffering. So it is important to explain about the disease and treat the symptoms.
Thank you, Dr. Anuja, as well as Dr. Suchitra Mehta for a very informative session. I have some questions to take this discussion forward. One is, when does palliative care start? So people have a notion that palliative care is only to remove the distressful symptoms, and usually for late stage state cancers. So when does palliative care really start in cancer treatment?
Palliative care should start right from the beginning. This is what in AIMS we have started. When a patient is entering in the hospital, 4 people are looking after. Medical oncologist, radiation surgical oncologist, and a palliative care physician. This is in oncology. But in these days in cardiology, end stage heart disease clinic, a palliative care physician is sitting. End stage stroke clinic, a palliative care physician is sitting. An epilepsy, where this intractable fits epileptic patient, a palliative care physician is looking after. Similarly, end stage pulmonary disease, a palliative care resident is sitting there. So it should start. It is not end of life care. End of life care is a part of palliative care, but it should start. And it is not necessary that if you don't have so many residents to sit, this does not mean that we should not start. I think all the healthcare providers should have a basic knowledge. Because, you know, whatever you say in all our curriculum, whether it is Ayurveda, whether it is yoga, whether it is MBBS, whether it is MD, we are learning only to diagnose and treat. That's all. We are not learning that there are something else which patient wants. It's ultimately a human being. So right from the beginning, what are the things patient wants to know? I think it should integrate right from the beginning. Anuja, you want to add in this?
Yeah, so definitely, I agree with Madam totally, and I think I've also said recurrently in my presentation that it should start right at the beginning, and it's not only at even before diagnosis at times, because patient may be symptomatic and patient may be coming to the hospital because of some kind of symptom or suffering he's going through, and is in process of evaluation of diagnosis of a cancer. And during that process also, why should the patient suffer? So we have solution to the suffering right at the beginning, and why not integrate it right there? So if it should start even before the diagnosis, I would say.
Thank you, Dr. Suchitra and Dr. Anuja, for your thoughts. One important question here is, what treatments and interventions are adopted in palliative care? So people have a wrong notion that it's only about giving medications or doing some other procedures, so like pain management. But what are the treatments which come under the ambit of palliative care?
So there are pharmacological intervention, there are non-pharmacological intervention. Non-pharmacological intervention, I always teach my resident that communication is the best non-pharmacological. Being with the patient is the best non-pharmacological. Besides this, there are multiple non-pharmacological interventions. One, yoga is one. We have conducted one trial on carcinoma breast patient. In one group, we used to give standard treatment. In another group, we used to give yoga plus standard treatment. And what we have found, that quality of life, understanding of the disease, and the understanding of the disease, and the quality of life of the patient. Those who we were providing palliative care and yoga were much better than those patients, and the quantity number of pills was requirement was also less. So it has to means like it is not it comes under non-pharmacological treatment, but in pharmacological treatment it can be interventional or non-interventional, means like giving medication and by giving intervention. We should give intervention when a pain is localized and we know that is a single nerve is innervation pain is there. We can give intervention and we can reduce the burden of pill and unnecessary side effects. So this is combined. This is basically a multidisciplinary or interdisciplinary approach. Anuja, you want to add something?
So I think, madam, you have said it all, that there are multiple things. And as I've also mentioned in my presentation, that it's not only one person who does palliative care, it's a teamwork, and we have to consider and each person in the team is equally important, and each person in the team adds value to the treatment. So I think it's a very integrative approach rather than one single thing or only pharmacological measures.
There's another question by one of the audience. What is the role of alternative medicine in palliative care?
So see, we are not expert in alternative medicine. I will not like to give a clear-cut answer, but definitely alternative medicine is an ancient medicine of this country. And there is a definite role of alternative medications. I know that about the yoga and meditation, definitely there is a role, because we have conducted the trial and we have seen, and even if I see myself, there is a definite role of yoga and meditation in my whole life to keep me disciplined and calm and understanding about the chaos, because life is going to create chaos every day, but meditation and yoga really keeps you on track. So all these things, and if we will integrate this in the continuum of care of any patient who is suffering with chronic disease, I think his understanding will be better. He will always remain positive. He will always think what is there in his glass. He will not think that what he has lost something. So I think there is a role. Plus there are ancient medication like ginger, haldi, so many things. I think there is really scarcity of proving all these medication in those means like intractable vomiting, intractable fatigue, intractable pain. We can introduce so many things, but you know, there is a gross scarcity of systematic trial. There is a gross scarcity of systematic research. That is why we are right now, I'm unable to give the answer that there is what is the evidence-based role, but there is a role, and I think we should conduct trials and we should conduct systematic research in this area and should come out, because we know that I still remember when I was in my childhood, when I used to get high grade fever, my grandmother just used to give me milk and a lot of usme turmeric haldi dal ke de deti thi, and she used to say that you will be all right tomorrow morning. So you know, why can't we create such kind of evidence in terms of our giving managing all intractable symptoms. You know, allopathic mein there are so many symptoms and we give allopathic medication and we keep on balancing side effects versus medication. So I think there is a huge scope of integration of allopathy and integrative medicine. Hello? Hello?
Thank you, ma'am. So there is one more, just to add on to this particular aspect. See, when the word used was alternate medicines, as far as NIH definition goes or WHO definition of alternate medicine goes, these are medicines which are taken in as a replacement for the conventional goal of treatment. Okay, so meaning to say, somebody who's supposed to take chemotherapy that doesn't want to take chemotherapy, wants to take some alternate cures, something for which we don't have any evidence. This is called alternate. And secondly, there's one more definition of this called complementary. Okay, so we use complementary and alternative medicine. So this complementary is where you use these kind of cures and therapies along with conventional treatment or standard of care. That's called complementary. And the third one is called integrative or evidence-based medicine. That is where you have some evidence for these kind of therapies. There, for example, ginger has been found to reduce nausea. Lemon juice is also found to be reducing nausea. Acupressure is being used for reducing or managing nausea and vomiting in chemotherapy-induced cancer patients. Yoga has been found to be having good level of evidence for managing fatigue. It is already in the NCCN guidelines for managing fatigue. So all these come under the ambit of integrative medicine. So when you start developing robust evidence and when you use those along with your conventional mode of treatment, that is when we call this as integrative. So this is just a definition for people who are asking about alternate medicines, because we don't need to use the word alternate. Alternate means a replacement to the standard of care. So we need to either talk about complementary or integrative, and that should be the way forward to take this. So you should also know that the National Center for Complementary and Alternative Medicine, which was there in 1994 as a part of the NIH, is now been rechristened as National Center for Integrative Health in 2014. So there's a lot of, in the last 20 years of time, a lot of efforts have gone in developing evidence for these alternate treatments, and because of the robust amount of evidence, the NCCM has now been rechristened as National Center for Integrative Health, and that's a very good step, because we are now moving towards integration. And in all spheres, if you see, there are Ayush therapies, there are other therapies also, as Dr. Anuja was talking about, energy-based therapies, biofeedback, yoga, Tai Chi, and other kinds of mind-body therapies, which can be really integrated in the cancer setting and help these patients. I have one question for...
Sir, before you move on to other question, I would just like to add to this, that as you rightly pointed out, that integrative medicine, integrative oncology, so there are departments even in various very good centers, oncology centers all throughout the world. So almost every standard oncology center has a integrative oncology department as well. And other thing about evidence, when we go through the Cochrane database itself, you will find lot of papers on integrative oncology. We have so many researchers from India as well. I think, sir, you've been doing research from 2004. I have read your paper of 2004 and beyond. So I've seen that there are many articles when we talk about evidences as well. So there are many articles for xerostomia, for fatigue, you see for mucositis, there are for wound management, you see so many alternative medicine articles, or rather I would not say the word alternative medicine, it's integrative oncology articles that you see for management of various symptoms in cancer. So I would suggest, rather than making it as sir rightly pointed out, it is this or that, you make it amalgamation of two things together and use it as integrative approach rather than making it as two separate approaches.
Absolutely.
Thank you, Dr. Anuja.
Absolutely. This is important that whatever is available, I think we should integrate, because there is no answer that this therapy will help or this therapy will help. Ultimately, patient is one and we have to integrate both the things.
There's another question, ma'am, for both of you. In your own hospitals where you experience palliative care and where you are heading the palliative care, what percentage of patients take recourse to Ayush interventions? And do you often come across these, and do they ask you any advice that they are taking these Ayush interventions, are they safe or not? So do you come across these kind of situations?
So almost, I think if I'm sitting in a clinic or I'm seeing almost 60-70 patients, at least 5 to 6 patients, they will definitely ask me that if there is no treatment possible, can I start taking homeopathy, Ayurveda, can I go there? So I always say that I am not expert in this, but definitely if you want, you can go if there is some reliable source or reliable person, you can go and take their help. So we don't refuse usually, but definitely we are not the right person to say that yes, you go there and it's going to help or something. So definitely there should be there should be integration in all the oncology departments, and there should be one person should be there so that anybody who wants to take help, and the person can guide them nicely.
Dr. Anuja?
So, well, I would like to quote one of the trials that was done in, I think, US. So this is about how many patients are on alternative and complementary therapies and how many of them actually report. So people may not tend to report to an allopathic doctor about any other integrated method that they have been following through or they are taking, because first is they might not think that we are experts. They might think that it is a part of their therapeutic regime, but since this doctor may stop their medications, I will not tell. So people may not report actually. So there are people who will report, but there are many who won't. And especially when we see in our OPDs, patients may actually be taking something or following some particular therapy, but it's like it is already integrated from their side, but it is not reported to the doctors. So I don't think we will have a clear-cut answer or opinion as to how many patients, because it's really not clear that how many patients are following integrative approaches.
Absolutely. Most of the patient, I think they try because whenever we say that patient is in advanced stage, they start looking for other therapies, and they are afraid. Basically, many a times they are afraid that if I will tell this doctor will stop my treatment, or this doctor may get offended, something like this.
And one more thing is about this is educating even the healthcare professionals at their level. Education is very important. Like for instance, we are totally unaware of what an alternative therapy is or an integrative approach is unless we start reading about it, because we are not taught about it in our medical schools. So I think that integrative approaches also needs to be focused upon at least briefly, so that we understand as doctors that this is one thing that can be integrated in management of our symptoms. So I feel education and training again becomes very important here.
Just to add on to this, Dr. Anuja and Dr. Suchitra Mehta, we have done a study in HCG, well back in HCG about 2 years back. We did a survey across 4 oncology centers, both in Bangalore, Mysore, and Mumbai as well. And what we found was we did a survey of around 800 patients nearly. And in this survey, we looked at patients with primary cancers with a non-metastatic disease. Okay, means to say early stage cancers. And what we found out was 25% of these patients took recourse to some form of complementary and alternative medicine during their primary cancer-directed treatment itself. Okay, and among these 25% of the patients who took recourse to this, 60% of them did not tell their doctor, and 60% did not tell their doctor because they felt the doctor is going to discourage them from taking recourse to this kind of an intervention. And we also found out what kind of symptoms these people are taking recourse to CAM. Many of them are taking it, saying that it is going to help with anti-tumor effect. It's going to improve their immunity. Many of them are taking it for reducing their fatigue and giving some amount of energy. And many of them are taking it to manage their pain as well. So there are various conditions which are there, and this is awaiting to be going for a journal publication, and we'll be doing it very shortly. And this is very interesting for us because to see that 60% of them don't want to tell their doctor that they are taking this, because they expect that there's going to be some sort of admonishment by the doctor for taking the recourse to this without informing the doctor. So that is one thing which is already there in cancer patients. So what is important here is, I also saw some questions here. Do you feel there is any interaction between these Ayush therapies and modern chemotherapy drugs, etc.? And is that one thing which is a worrying factor for most of these, both the physicians as well as the patients? What is your thought on this?
So about interactions, well, I am not very sure because I have not read about Ayush therapies much, but what I recommend to my patients again is if somebody would ask me that whether I should be taking this Ayurvedic medicine or not, I would actually talk to the Ayurveda doctor and tell that these are the medications that I am giving to the patient. Will it have any interactions? So I feel the coordination in the teams is also very important here. So that is what I follow. I would talk to their doctor and talk about what are the additional benefits of what you can provide or what I can give more additionally to add to your treatment. So I think it should be overall, it should be a patient-centered approach rather than individualistic management approach by each doctor. So I think it's the coordination between the teams there is very important.
Yeah, that's well said. And there's one more thing which is there, especially you roll out Ayush interventions in end-of-life care. Do you have something to add to this?
Ayush intervention at end of life care, I don't have any idea what are the Ayush but definitely again with our ancestral and whatever the ancient practices which we there is always a reason what practices we are following during end of life care. I think there should be some connection, but I don't have any intervention.
So, I think Ayush interventions at end of life care, what I have seen has helped is for therapies for mood disturbances like music therapy, or even therapies like sometimes for management of xerostomia, because it's very common and very distressing. Wound management therapies at times, or even some of the interventions like healing touch, or something that would also be like energy conservation techniques. So these things I feel can have a role in at end of life care as well, which will be actually, it will have a role all throughout, but end of life care, I think the role increases even more there. And especially energy conservation techniques, because fatigue is very common and very distressing at end of life care.
Thank you.
End of life care centers.
Absolutely right, Anuja. I think music therapy, energy conservation, but this will be definitely if there is a lifespan of few months or few weeks.
So what we have done in our ward patients at times, that we've told the family to use a soothing music to calm them down, to reduce that, and it helps in reducing the distress, overall distress. We've seen the moaning of the patient comes down, or even those objective measures of distress would actually settle down, like pulse rate would instead of being very tachycardic, sometimes it might come down. So those things I think helps a lot. Beyond this, I'm not very sure because I have not actually seen much of integration there otherwise. But I'm sure sir would be able to highlight more upon what all other things that can be addressed at end of life care with Ayush measures.
I'll just give you a small episode where I had a chance to be with one of the patients during her deathbed. She was a terminal case patient who was in a hospice care in a place called Karunashraya. It is a very hospice center in outskirts of Bangalore, and people there had called me to just help her out with seeing to see whether yoga can really help her out. But what we need to really see here is that to being with the patient and counseling the patient, trying to give comfort to the patient, even with few words is also enough. Now this patient had intractable pain, and she was just had a few days to live. That's what was the thing, and our family had admitted her to the hospice care center, and her pain was not going down. And what was happening was, even though in spite of all the good pain management strategies being given to the patient, she was in so much of distress, and her son was not able to see her, and he also happens to be one of my family friend. So he requested me to go and talk to her, and whenever I started talking to her, her main concern was who's going to take care of the dog which is there in her house. Okay, she had no concern about anything else. Whenever I started talking to her about pain and other things, she used to not talk about the pain, but she was talking about after she passed away, who is going to take care of the dog. And this is something very, very peculiar for me to hear. And none of them had paid attention to her requests. Neither her family members had paid her request, heed to her request. They said they'll take care of the dog, but I believe she was not comfortable leaving the dog with her family members. That was what is the problem. So I got a friend of mine who was who takes care of animals and who is an animal lover itself. He wanted to adopt the dog. And after she talked to him, the next day morning, the doctors call me and say, she doesn't have pain today. She doesn't have distress today. So there's so many things which are there for patients. Sometimes the end of life care doesn't mean that it is only the yoga intervention you want to do or breathing exercises you want to do for the patient to give them succor. For some patients I've seen, one of the patient was there, she wanted to see her son get married. Okay. And she was in the terminal illness, basically in the hospice, not in the hospice, she was in the hospital in our HCG. And we talked to convince the son, and she had also found a partner for him. He agreed to marry that partner, and we got the marriage done, solemnized in the ward, in the hospital itself. And this lady died very comfortably, with a lot of peace, with a lot of happiness. So that dignity in death is very, very, very important. Trying to fulfill the last wishes sometimes, and this also really, really helps. And giving anything which can give mental succor to these patients during this time of dying is what is really important. So it doesn't mean it's only Ayush intervention, or you give some herbal decoction, or you give some yoga, you this or that. At that point of time, I don't think anything really, really works to really enhance the lifespan or anything. We have seen people who do homums in the house. They go to temples, they worship, they do this, they do that. So many rituals they do at house, right? And we don't say that, we don't stop the patients from saying that don't do the rituals, because they do it because they get mental peace. Both the family members also get the peace, as well as the patients also find some sort of solace and succor in that. And during these times, we ask them to do these things because this is really helpful, because it is improving their quality of life. It is reducing their distress. So this also becomes an intervention for this patient, because at that time when doctors are also not able to do anything, are not able to offer any sort of solution. So it will not be just any sort of therapy. It can be anything, I can say. So even just talking, counseling, comforting, doing all these kind of therapies. I have seen patients, who are looking at palmistry. There was a person who was doing his PhD in astrology who came to our hospital and was just trying to look at the palmistry of all the patients. He used to even determine the time of death and other things as well. So patients even take recourse to such kind of things when the end of life care, especially when the end of life comes. Okay, they are very, very disparate. They want to, some people want to enhance or prolong the life. Some people want to reduce the suffering and distress in this population. So each person has got a different goal. And what should be our idea or ideation here is to see how we can fulfill that person's goal. Okay? And if you're able to do that, you can bring some amount of solace, you can bring some amount of dignity in their trying and reduce the distress as well. So, Dr. Sushma, anything else to add on to this? You must have seen, most of you must have seen a lot of patients at end of life care, and you must have had this kind of an experience.
So absolutely, Dr. Raghavendra, I think when you know that end is inevitable, it is. Yes. Hello. So can you hear me?
Yes, ma'am. Yeah.
I am just saying that when end is near, when we know that we are not going to do anything for the disease, I think it really matters that being with the patient and giving them a holistic approach, whichever way possible, by treating intractable symptom, being with patient, listening to the patient, what are their unfinished business, what are their unfinished work. I think this everything makes a huge difference in the patient's life.
Yes, and I don't think there is a clear-cut protocol here. It has to be very individualized. It has to be individualized and overall focus on healing of a person rather than curing or finding clear-cut answers every time.
And every end of life experience is different. Because every life experience, end of life experience teaches us something, that this is what we can do. We can make a difference. Yes. Okay, then.
So we are nearing the end of the session, and I thank Dr. Sushma Bhatnagar and Dr. Anuja Damani for giving their valuable time and expertise and sharing the expertise with all of you on this platform. And we hope to see you again, madam. We are planning to start some sort of courses. And I think Dr. Naveen Sarins, who is a mentor to Dr. Anuja, also knows this. We have started this course, Integrative Oncology program for therapists at HCG Hospital about few years, 7 years back maybe. And I think we're going to start this again from CCRYN along with all the hospitals. And we will try to make this as a successful program where we can train Ayush doctors in various aspects of palliative care and psychosocial issues in cancer patients as well. So thank you so much and for being here with us. It's been a very informative talk. We have had good interactions, a good number of sessions, and consistently we have seen the same number of people still on the platform hearing to the lectures. And because these lectures have been so informative, and kudos to all of you for this session, madam. Thank you so much. So we go over to the next session. So we go over to the next session now. We have going to be talking about the role of yoga in cancer. So we have two great speakers. One is Dr. Nagaratna Raghuram, who is the Dean and Medical Director at Arogyadhama Prashanti Kutiram at SVSA University. I'm sure most of you here who are the attendees here know her very well because she's been a stalwart in the field of yoga since 1975. So her first publication, which was published on yoga and asthma in 1980 in BMJ, British Medical Journal. So there was a high impact paper on yoga and asthma, which was published very, very early in those years. And since then, SVSA has come up in leaps and bounds, thanks to the mentoring by Dr. Nagaratna as well as Dr. H.R. Nagendraji, that it has grown to a very big stature. So we also have another speaker, a prolific speaker, and a medical oncologist herself. Dr. Vinoda Kochupalai was also the director of the Rotary Cancer Hospital at AIIMS, New Delhi. Okay, she's a very, very senior medical oncologist and a mentor to all the living medical oncologists, all the senior medical oncologists today in various hospitals across the country. And she's been a mentor, a guru, and a teacher. She herself is a very great proponent of Sudarshan Kriya Yoga. She is now the director at Art of Living in Bengaluru. And I request Dr. Anusuya to give a word of introduction to both these speakers. Dr. Anusuya, is Dr. Vinoda Kochupalai joined?
I've just given a message, sir. Even I'm trying to call, but not able to connect it to her, sir.
Okay, I'll collect it. You can start giving the introduction to both of them.
Yeah, sure, sir. Sure. So this is again a time to start our third session of the seminar on the topic role of yoga in cancer management. And it's really my privilege and honor to welcome Dr. Nagaratna ma'am and Dr. Vinoda ma'am who are with us today. And Dr. Nagaratna ji is, everyone knows, and director has given a very good introduction about her. And just adding to that, I'm just adding to that one. She is one of the pioneers in the field of yoga therapy. She's the Dean and Division of Yoga and Life Sciences and Chief Consultant at Arogyadhama SVSA. And she did her MBBS and MD in Internal Medicine from Mysore Medical College and MRCP and FRCP from Edinburgh, UK. She has over 150 publications in national and international journals and has over 11 books on series of yoga for different ailments. She has been felicitated with numerous awards, such as the Patanjali Award for the contributions in the field of yoga and Dr. P.S. Shankar Vaidyashri Award for Women of Excellence Award for her service to humanity through yoga therapy and Karnataka Kalpavalli Award for service to women through yoga and many, many more on her part. Now, moving on to Dr. Vinoda Kochupalai. She was the professor and head of medical oncology and head of cancer center at AIIMS, New Delhi for over 32 years and was a medical director at Asara Medical College at the hospital at Kalatur, Kanchipuram district at Chennai for over 3 years. Currently, she is working as advisory director of Ashri Institute of Advanced Research at Veda Vignan Mahavidyapith at Bangalore. At AIIMS, Vinod Kochupalai developed a full-fledged 150-bedded cancer center with all the required facilities. She is a recipient of several national and international awards or recognitions, including Dr. B.C. Roy National Award in the category of Eminent Medical Teacher. She has been a visiting scientist at UCLA at Los Angeles, Harvard School of Dental Medicine at Boston and Chicago in USA. She has also been a visiting scientist at Moscow and Budapest. She has published over 187 research papers in national and international journals. She is currently working on DST and Ayush funded projects at Sri Sri Ravi Shankar Institute in Bangalore. So really, it's my honor and privilege to introduce them. Now, please, the director, Dr. Raghavendra Rao, may continue the session, please.
Thank you. Thank you, Dr. Anusuya. And now I request Dr. Nagaratna to please come on the dais and give a presentation on the role of yoga in cancer. Over to you, ma'am. Dr. Nagaratna? Ma'am, Dr. Nagaratna, can you hear me, ma'am?
Yeah, I can hear you. Can you hear me?
Yes, yes.
You can
Just on your camera, madam. Namaskar, madam.
Namaste.
Namaste, madam. We can hear you.
Namaste to one and all.
Namaste, ma'am.
I can't hear. I can't hear you.
Madam, we can hear you. Maybe I think you have to take out your earphone, ma'am.
Hello. Oh.
Madam, you may have to log out and log in again with your earphone on because your ear.
Am I audible, Raghavendra?
You're audible, madam.
Okay. I'll share the screen. I'll start with a small presentation.
Yes, ma'am.
Before I go into the actual questions. I'll share my screen.
Please go ahead, madam.
Yeah. Okay. ಕೇಳಿಸುತ್ತಾ ನಿಮಗೆ ನಿಮಗೆ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ
ನಮಗೆ ಕೇಳಿಸ್ತಾ ಇದೆ madam. We are hearing.
Is my screen visible now?
Yes, madam. You can go ahead. You can make it in slide mode, madam.
Yeah.
Yeah.
Namaste to all of us on this occasion of the World Cancer Day. We have been celebrating World Cancer Day year after year. I hope with the advances in modern medicine and complementary therapies, people will get a stage where cancer will become like diabetes. There was a time when diabetes was like this. Once a diabetic, he would be gone in 5 years. Similar has been the status in cancer. Definitely COVID has been worse than that, of course. So I hope we'll reach a stage where cancer becomes something like diabetes, where people learn how to manage it by looking at the inner system than the outer system. Let us all begin with one simple deep omkara. Take a deep breath. Om. Friends, I know this is a panel discussion. I'll just take about 15 minutes to give you a quick overview. As you have been hearing, there has been a lot of awareness about the use of complementary therapies. A glimpse is seen there. Ayurveda is used to the maximum. Then comes homeopathy. Then comes yoga. There are a large number of publications. Meta-analysis is the highest evidence in medical science, which has shown that psychological distress comes down with yoga, anxiety comes down with yoga, and this is Dr. Raghavendra's study, which he published in 2004, where he was able to show significant reduction in the immune system being stabilized with yoga, which was published in International Journal of Yoga. Fatigue reduced after yoga. We have all been hearing a lot about all this. Let us go ahead and see how the most important thing in cancer patients is the quality of life, which was again demonstrated with significant reduction, improvement in quality of life of these participants. And there are large number of studies which have talked about the mechanisms. I'm just giving a few overview. Stress reduction is a very important factor in managing cancer. And Dr. Vadiraja's study showed significant reduction in salivary cortisol. And Dr. Banerjee's study showed a significant improvement in the immune system. When people go through radiation, the DNA gets damaged. What Banerjee showed was there was significant reduction in DNA damage after the radiotherapy as assessed by Comet-assay studies. In spite of so much of advances in medical science, why is cancer going on increasing? We know that we have to tackle the cause of the disease. External factor is one of the major causative factor. The chemicals that go into our body without our awareness in the form of insecticides, preservatives, coloring agents in food and drinks, air pollution, electromagnetic radiation, these are external things about which we are able to become aware and trying to avoid by shifting to more and more organic foods and organic drinks, avoiding junk food, avoiding non-vegetarian food, etc. And there is enough external awareness which I hope will help us to clear these external factors, which is definitely going to take a lot of time. But the internal factor, we know that there is the internal genetic factor, which may be a strong family history, which is responsible for childhood cancers, but lifestyle is the major factor. And as all of us know, what is cancer? There is uncontrolled multiplication of cells, and always every cell has to survive that long and die away. Multiply, dissolve, multiply, dissolve, multiply, dissolve. And this is a balance that is set into every one of us. There is no cell that lives as long as I live. If I'm 60-year-old, no cell in my body, including the brain cell, is the same as I was born. So this all apoptosis or dissolution of the cell is very important. And what is cancer? There is an imbalance. The number of cells multiplying due to this external irritants and the immune system being weak, which has to dissolve away these abnormal cells which escape the apoptosis, is the factor which all of us are familiar. And therefore, what is very, very important to look after this internal factor is to bring about a balance between the multiplication and destruction, and balance between new cells being formed and then gobbled away by the immune system. We know that there are large number of lymphocytes which dissolve away abnormal cells that may escape and create problem. But what is very, very important is the lifestyle. So what are all the things that we need to take care of to prevent cancer, treat cancer, and help people during palliation, even up to the end of life? It is a lifestyle, which is all controlled by diet, lack of physical activity. We know that obesity is one of the major components, and wrong habits, eating habits nowadays, screen habit, stress, all traceable to the mind. So yoga addresses the mind. It is the skill to calm down the mind and reach a state of total health, which is beautifully described in Ayurveda's balance at all. They were saying this is very easy, but how to do it? This is where the yogis gave us 5,000 years old of technology, which is called as integrated approach, including yogic diet. And we take them to detoxification through kriyas and bring them to a state of mind, because we realize that it is the mind management which is very important. And so, Samyama is the state in which deep-seated genetic program can also be changed, where we do deep levels of dharana, dhyana, samadhi together, where Patanjali beautifully says bring the mind to a state of zero thought state and put in a single thought, and that strengthens the system. For this, the whole of the summary of what we do at this center is, as a yoga management program, is to give deep, conscious, wakeful rest to the sick organ. And the whole process is described as Prayatna Shaitilya Ananta Samapatti. Prayatna Shaitilya is to slow down, Ananta Samapatti is to expand the awareness of the individual. And for this, we have several psychological techniques which we are using at our center. One of the very popular techniques which is used by thousands of cancer patients is mind sound resonance technique. And this is a one where the resonance works. I am requesting one of our participants, Mr. Prakash Rekere, who has cured himself, if I may use the word, as a patient with prostate cancer by using this MSRT practice. I request Mr. Prakash Rekere to take over and talk to us for the next 5 minutes about what you are, what you think you are, is what he achieved in his life. Mr. Prakash.
Thank you, Dr. Nagaratna, and thank you for giving me this opportunity. I am one of the cancer survivors, and I keep talking to cancer people. I must have spoken to about 500 people. I visit hospitals whenever I get calls from the patients or their relatives. I have visited various hospitals in Mumbai and other places to talk to people. So briefly, my history is I was in a very advanced stage of cancer in January 2014. And there was heavy swelling. I was bleeding profusely. There were thick clots in the bladder. My urine had stopped. And it was very pathetic situation. I had lost a lot of blood. I was not able to walk even 25 meters. That situation, I landed in India from US. Actually, I was traveling. So a lot of tests was done, and at 8 o'clock I was in a hospital, and 9 o'clock I was on a operation table to remove the tumor from the bladder, to make the urine through, remove the clots and all that. So much psychological pressure, all those things were there. And then both my children were in US, so I was in great trouble. But then I accepted the reality and moved with the treatment that the doctors had suggested. And then went back to US in that condition because doctors had given me a couple of months, 3 to 6 months. I wanted to go to US and then spend the rest of the time with my children there. But I ordered a lot of books and tried to study why cancer to me, why cancer to my wife who died with cancer. And a lot of analysis I did. But then the real analysis was after I came back to India and I came to Arogya Dhama again. And then I tried to understand why we should do all these practices, how they work on our body. I read a lot of books on body anatomy and then applied those things, how I can heal myself. And this is what I discuss with people. One of the important techniques that I analyzed scientifically was MSRT. It's not just doing the practices. We must understand why those practices should be done and how they work on our body, and that too at cell level. Because this is a cell level disorder. I wouldn't call that a disease. This is what I keep telling people. This is a chart of my PSA value and tumor in centimeter squares. I kept a plot of all those things, and you can see how the tumor size reduced without taking chemotherapy and without going through any radiation. And this is what I keep sharing with people. what is the scientific evidence of MSRT, how it works on the body, how Onkar works on the body, how we should practice it. Like some people having brain cancer, they should do MSRT in a specific way. They should do Nadana Sandhana Pranayama in a different way. How we should do pranayama, like I understood, I analyzed. So the only way, like if I do pranayama for 15 minutes, I should be able to listen to my own heartbeats. That is the only way when the pranayama becomes very effective. There are various other techniques that I followed, and I keep sharing them with people, go to their homes and try to convince them. And many times the end of life people also, I see to it that they die in a peaceful manner, which is most important in the case of cancer patients. Thank you very much.
Friends, we have several such cases where it is very, very important to see that the mind component has to be tackled with the idea. The first and the foremost thing that we impress upon participants is that fear of extinction, survival instinct, the fear of death. If that goes away right at the beginning of the treatment, then all these techniques will start taking over. Thank you very much. Over to Dr. Vinodhaji.
Ma'am, can you just stop the slide share, madam?
Yeah.
Yeah, thank you. Over to now Dr. Vinoda Kachupillai, who's here from the Ved Vigyan College. That's the Art of Living in Bangalore. Over to you, madam.
Thank you, Dr. Rao. Good morning.
Very good morning.
And thank you, Dr. Nagaratna. Nice listening to you. So can I have my presentation, Dr. Rao? Okay, thank you. So before taking the questions, I would just like to talk about the effect of Sudarshan Kriya Yoga as an adjunct to cancer management. This is a picture of Vishalakshi Mandap in Art of Living Center. And this is the place where I'm working right now. Next slide, please. Yeah. We all know that diagnosis of cancer as well as its treatment are highly stressful events, not only for the patient, but also for the whole family. And this experience of distress is generally not addressed when we are undergoing medical training. And also as an oncologist, we are not told how to handle it. But we now know through various publications that stress and depression are associated with the worst survival in a given patient. In other words, now we have a scientific evidence that chronic stress promotes cancer growth and its progression. Next slide, please. Now, what are the mechanisms? How does stress cause progression of cancer? There are primarily 4 ways. One is that stress influences negatively natural killer cells and their activity. Secondly, stress also leads to poorer repair of damaged DNA. Third is that it modulates apoptosis in a negative way. And fourthly, the psychological stress also aggravates oxidative stress. Next slide, please. Now, let us first talk about the natural killer cells or NK cells. NK cells, we all know, are the surveillance cells of the immune system, which destroy tumor cells and also infected cells. Stressors, or the stressful person on the other hand, there is a decrease in the lymphocyte proliferation, and there is also reduction in the NK cell cytotoxicity. Interferon and interleukin-2, which otherwise enhance NK cells and leukocyte activated killer cell activity, they tend to get depressed due to stress. Smoking, which many cancer patients are used to, further reduce NK cell cytotoxicity and thereby leading to progression of the cancer. Next slide, please. Next slide, please. Now, ability to repair DNA damage is impaired in those who are having depression due to cancer, which leads to cancer and or its progression. Next slide, please. Apoptosis, it is a genetically programmed process which eliminates damaged cells and prevents process of carcinogenesis. Now, this process is also impaired due to stress. Next slide, please. Okay, now let us talk about oxidative stress. Reactive oxygen species generated due to external sources like environmental pollution or body's own metabolic processes leads to oxidative stress, which is aggravated by psychological stress. And this process leads to atherosclerosis, chronic heart diseases, rheumatoid arthritis, and even cancer. Now, antioxidants such as glutathione, superoxide dismutase, catalase, and glutathione peroxidase, they prevent oxidative damage. It's a balance between reactive oxygen species and antioxidant defense, which decides whether a person stays healthy or suffers from a disease. Next slide, please. Now, so if we agree to this fact that stress leads to cancer and its progression, then it is reasonable to say that stress elimination could improve immune functions and or antioxidant defense, thereby leading to a decrease in the progression of cancer. It has been shown by the studies that various relaxation techniques increase NK cell activity. For instance, Fauji et al. Published a paper where he showed that 6 weeks of relaxation program increased NK cells, increased NK cell cytotoxicity, and there was a lower rate of recurrence and death in malignant melanoma patients compared to the controls. Next slide, please. Also, there are studies by Spiegel et al. And Goodwin et al. Where they have demonstrated that women with advanced breast cancer lived longer and had better quality of life when they underwent relaxation techniques. Next slide, please. India is an originator of many important relaxation methods. In fact, yoga, meditation, and pranayam are the centuries-old, time-tested processes which are known to energize the body and relax the mind. I am going to talk about Sudarshan Kriya Yoga. Sudarshan Kriya is a rhythmic process and it is conveyed to the participant through Art of Living Happiness program. Next slide, please. So as I said earlier, Sudarshan Kriya is a rhythmic cyclical breathing. It is preceded by Ujjayi Pranayam, which has slow breathing against airways resistance for 3 cycles per minute. And it is then followed by Bhastrika Pranayam, which is done by rapid exhalation, 20 to 30 cycles per minute, and followed by brief Om chanting. It's all done in sitting posture, but it ends with 20 minutes of rest in supine position. Also, we know it as Yoga Nidra. Next slide, please. Now, physiological effects of Sudarshan Kriya Yoga have been studied at AIIMS New Delhi and also at NIMHANS Bangalore and some other places also, as I'll be talking a little later. For instance, we studied police trainees who are highly stressed people, and we showed that even though the control subjects, their blood lactate level continue to be high, but those who practice Varshakriya, their blood lactate levels drastically reduced, statistically significantly. Next slide, please. Similarly, electroencephalogram showed that beta activity, beta power was much higher in those practicing Sudarshan Kriya. And also, next slide, alpha activity increased in those who were practicing Sudarshan Kriya. Next slide, please. Dr. Manveer Bhatia and a neurologist and EEG expert interpreted her data as showing that beta activity indicates activation, alpha activity indicates relaxation, and therefore Sudarshan Kriya Yoga leads to a state of relaxed alertness. Next slide, please. She further opined that changes in alpha and beta activity following Sudarshan Kriya Yoga suggest increased connectivity and greater information processing in the brain. Next slide, please. We have also demonstrated among police trainees that levels of antioxidants like glutathione, catalase, and superoxide dismutase drastically increase compared to the controls among those who practice Sudarshan Kriya Yoga. Next slide, please. All this work has already been published. Next slide. Further, we did 2 studies with regard to NK cells numbers. First study, we compared the normal persons, cancer patients in remission, and those practicing Sudarshan Kriya Yoga for at least 2 years. And as you can see in the slide here, that those in the center slide, center picture, that those who practicing Sudarshan Kriya Yoga had statistically significant increase in NK cells compared to the normal subjects and cancer patients. And the second study we did among cancer patients and demonstrated that those cancer patients who did Sudarshan Kriya Yoga regularly, their NK cells increased compared to those who did not practice it. Next slide, please. And therefore, we can say that increase in the NK cells and antioxidant defense, as we have shown with Sudarshan Kriya Yoga, may be able to protect or delay the onset of several diseases, specifically age-related diseases, including cancer. Also, those patients who already have cancer, there the practice of Sudarshan Kriya Yoga may slow down its progression. Next slide, please. Dr. Fari at Norway studied the gene expression among peripheral blood mononuclear cells of the practitioners of Sudarshan Kriya Yoga and compared with the controls who did the nature walk and who relaxed with listening to music. And he demonstrated rapid and significantly greater effect on gene expression in Sudarshan Kriya practitioners. And he said that this may be the basis for long-term cell biological and higher level health effects of Sudarshan Kriya Yoga. Next slide, please. Gene expression studies were done at AIIMS New Delhi also by Dr. Neeta Singh, and she demonstrated increase in the antioxidant enzymes, prolongation of lifespan of lymphocytes, upregulation of the anti-apoptotic COX-2 and BCL2, and cytoprotective heat shock protein 70 among practitioners of Sudarshan Kriya Yoga. And she said that because of this upregulation of these genes, there is improvement in the immune response and improvement in atheroprotection. Next slide, please. She said, Dr. Neeta Singh said, that Sudarshan Kriya Yoga may exert effect on immunity, aging, cell death, and stress regulation through transcriptional regulation. Next. Taken together, she said that these results suggest that Sudarshan Kriya practitioners are resistant to oxidative stress and show higher level of protection from cancer and from cardiovascular disease. Next slide, please. We have also shown that at least 21% of subjects, they gave up smoking when they practiced Sudarshan Kriya Yoga. Next slide, please. 2 independent studies done on breast cancer patients One was done at Palo Alto in California, USA, and another one was done at AIMS, New Delhi. They showed significant improvement in the quality of life, increase in NK cells, and also demonstrated reduction in the side effects of chemotherapy. Next slide, please. So I can conclude from whatever I have said so far that Sudarshan Kriya Yoga as a preliminary studies indicate that Sudarshan Kriya induces relaxation response, increases NK cells and antioxidant defense, helps reduce addiction to tobacco, decreases side effects of chemotherapy. It exerts effects on aging, cell death, and stress regulation through transcriptional regulation. Hence, I can safely say that Sudarshan Kriya Yoga is a useful adjunct to cancer management. Next slide, please. Our ongoing project, which is funded by Ayush itself, is the study of Sudarshan Kriya Yoga on NK cell cytotoxicity. And I hope that by next World Cancer Day, I may be able to give you the results of this study. Thank you for giving me an opportunity to participate in this important event. Thank you, Dr. Rao.
Thank you, madam, for a wonderful presentation. It is heartening to see that you're already working now on SKY in cancer patients. I'm also aware of this study, and I hope we get some good data on NK cell cytotoxicity and role of yoga in modulating the same. Before now, the time is now for question and answer sessions. Many things, there's a lot of curiousness about what kind of yoga should be used in cancer patients. So this question is for both of you. So you can take turns to answer this.
Maybe Vinadaji will answer.
Well, actually, my experience is limited to Sudarshan Kriya Yoga. And as I have already presented, that this certainly helps. But as to the specific asanas, I think you may be able to tell us better, because I know that you have lots and lots of experience with different asanas for different diseases. So I would like to hear from you, Dr. Nagaratna, as to which asanas.
We have been using the integrated approach of yoga therapy, which includes lifestyle change, which is very, very important. And amongst this, there are change in the diet, cleansing techniques, physical postures, breathing exercises, meditation, relaxation, etc. And we do a lot of yogic counseling or talking to the participants to make them understand the conceptual basis of how important the mind is, how important the role of stress and fear, etc. is, and how to allay that fear by using concepts from Bhagavad Gita, Yoga Vasishtha, Patanjali Yoga Sutra, Satipradipika, etc. One simple thing that all our participants understand is it is not a particular asana or a particular pranayama that is important. Yoga is mind management, mastery over the modifications of the mind through this process of slowing down, calming down, relaxation, rest. And our experience, and I'm sure many of the complementary therapists' experience, is to handle large number of patients who are in stage 3 or 4, and they are hardly capable of doing any physical asanas which we see on the TV. As soon as we say it is yoga. In fact, I have many patients who say, no, I won't come for yoga because I can't do yoga. I'm bedridden. I'm very weak. I'm very tired. I'm exhausted. How can I come for yoga? So this is where we have developed many techniques which people can do lying in bed or just standing in just next to their bed, starting from physical practices, which we call as cyclic meditation. Then breathing techniques, lying in bed or sitting in a chair, we teach them simple slow breathing practices. Then we teach them many physical postures which they can do in a chair, sitting in a chair. And in cyclic meditation, we use only 4 postures, which are extremely simple. But the concept of Prayatna Shaitilya, concept of Pratyaya Ekatanata, effortless flow of a single thought on the background of awareness without any other disturbing thoughts is continuously imbibed into the participants. And as Mr. Prakash was mentioning, mind sound resonance technique has become one of the most popular techniques, which they lie down in their bed, just put on the audio instructions and feel the resonance all over the body and feel how this deep intrinsic resonance can bring about corrections at the molecular level. Then we have prana energization technique, which many participants develop after they learn the breathing practices, in which they energize the weak cells and then dissolve the abnormal cells through this intrinsic awareness. Mind is the most powerful stuff we know, but how to channelize those negative thoughts, make the negative thought zero, put a single positive thought. First, silencing the mind is the preparation that is very important. I think as I can go on and on, we have 8 such techniques: mind emotions management technique, mind imagery technique, Vijnana Sadhana Kaushala, where we ask them to understand the concept of fear of death and eternity of my body of partners, Deyatitata, etc., and take them through Ananda Amrita Sinchana, which is the one which helps them to dive deep into themselves and experience that blissful experience.
There's also a question for you, ma'am. Do you think that there is something specific to cancer? You have a specific yoga technique, like a specific yoga technique for breast cancer, a specific one for brain or lung cancer, and so on and so forth? Or is it more related to the patient's symptoms? Based on the patient's symptoms and the condition, we tailor the yoga intervention.
See, yoga, Ayurveda, all traditional systems of management are very individualized, depending on the capacity of the person. But if a person is capable of doing all the asana which I want to teach, capable of doing all the pranayama that I want to teach, we select those particular set of practices which Patanjali and other texts, yoga, this Mandukya Karika gives us. The principle of healing is to stretch a part of the body to bring awareness to the sick part of the body. So if the person has got breast cancer, we have to bring in those stretches which will bring her awareness to the breast area. If a person has got spinal fracture, spinal tumor, then we have to give a gentle stretch to the sick part of the body so that the part can be focused upon. And when they are maintaining in the final posture, they should be able to go into deep, conscious, wakeful rest to the sick cells in that area. Therefore, we have a template of a basic set of practices in which we emphasize on some stretches which help in giving local awareness with deep local rest to the sick part. This is beautifully brought out by Patanjali by 3 sutras. Sthira Sukham Asanam, Prayatna Shaitilya Ananta Samapatibhyam. While you are maintaining in the stretch, bring your awareness to that particular stretched cell or stretched tissue or stretched part of the body and bring about Prayatna Shaitilya there. Deep conscious relaxation suggestions are to be sent and diffuse from that area to experience that deep silence in that area, the ananda in that area. Therefore, as you rightly pointed out, Dr. Rao, we definitely need to change the set of practices to bring the awareness to the organ where there is a damage when we do the postures.
Dr. Rao?
Yeah, 1 second, ma'am. Just a second. Yeah, anything for you to add, madam?
No, I want to ask Dr. Nagaratna about a little bit more about this MSRT technique.
Yeah.
Yeah.
Let me ask Prakash to explain. He has got as an engineer, has got a very engineering oriented answer to the question of MSRT.
The way I understood MSRT is, the basic principle of resonance. Resonance is actually every molecule or every object. It has got its own frequency, which is called as the resonance frequency. And what we are doing in MSRT is we are trying to resonate the different cells. In resonance, actually what happens is it is amplification of signal. So it is our own voice which I am using and generating that signal which matches with the resonance frequency of the cells in the body. And in one of the papers that I read, which was published by the Physics Forum, okay, the body resonance frequencies have been given. They are within the range 0 to 150 cycles. So all the body organ frequencies are within that. And another paper that I have for reference is Human Resonance, which the very first sentence says that the Omkar that we chant, or the ancient Indian rishis used to chant, is directly related to the resonance of brain. And it is 7.81 cycles. He has published that paper. And then this is actually the primary resonance, what he says, and then you add 5.94 to this basic frequency and you get different frequencies of brain. And this is also true because as you experience during Omkar, there is a lot of silence that is experienced and the cells are actually resonating. So in the body, it works against the laws of physics. When you give energy to the cells, they actually go in silence. Unlike in the other case where you give energy to like a car, you give fuel, then there is acceleration. You give energy to water, it starts boiling, then to steam, which has a lot of energy. But in the case of body, when we chant this Omkar or Akar, Ukar, Makar, which is done in MSRT, all the cells in the body, they get a resonance effect and they become silent. And that is where the stress levels are drastically reduced and you get a different kind of feeling. And in MSRT, we also take a sankalpa at the end, which is related to your body, not related to any God or any spirituality or anything. So assuming or whatever Bhagavad Gita says that Brahmasmi, so there is God within you and whatever sankalpa you are taking is related to your own body. So it's very effective. So at the end of MSRT, or even when I conduct MSRT classes, you see people snoring at the end of 5 cycles or 6 cycles. That's because there is so much of energization of the brain cells.
Thank you. Thank you.
In MSRT, it is a 25-minute program in which we start with chanting Ah, which resonates the lower part of the body, O, which resonates the middle part of the body, Makara, which resonates the head region, and Omkara, which resonates the entire body. So there are 5 cycles of that, followed by Ahata and Anahata. We do loud chanting, followed by silent chanting. Then we use a mantra, Mahamrityunjay mantra in Indian situation, or any other mantra depending on their religion, to resonate the whole part of the body, to tune their mind to the divine energy. So it's a 25 minutes program with 8 steps, ending with the deep relaxation, tuning to the universal consciousness, and putting up a deep sankalpa.
Thank you, Dr.
I may also add, this also affects the dormant cells in the body because the dormant cells are our own deformed cells. So they will very well lie within this frequency range, 0 to 150 cycles. So not only the active cells, the dormant cells, wherever they are hiding, even those cells will get resonance.
Thank you.
So, just to add on to this, madam, I'll just tell you about my small experience with MSRT in one of these patients. This is one of the first patients we used, where we used this MSRT in HCG Bangalore Institute of Oncology in 1998. And this is a very difficult case, challenge case given to one of the oncologist surgeons who said, look, this patient has breast cancer. We need to operate this patient. So last 3 months, she's coming to the hospital, getting admitted to the hospital for getting a surgery done, mastectomy done. And the night before, she runs away from the hospital. And she had severe anxiety and neurosis and palpitations, and she didn't want to take treatment. So 3 consecutive times, this is a patient who was a middle-aged female, around 36 years old, with right breast cancer, and she was supposed to be undergoing mastectomy with axillary clearance. Okay, it was stage 3A or 3B, something I remember. And this patient was time and again running away from the hospital. So I had to talk to the patient. She refused to come to the hospital. So in fact, I went to the patient's home, and for a week or so, we started treating her. And I also remember asking madam also regarding what to be done. And finally, we started doing on MSRT for this patient. And she was able to overcome her fears. She came within a matter of 2 weeks. She came to the hospital and she underwent treatment there. She undertook this mastectomy. And finally, and this was very, very useful. And what I have also seen with my experience with cancer patient is this one technique, which is where most of the cancer patients feel it is very, very useful for them. And their anxiety, the palpitations drastically come down after doing MSRT. You've seen this very, very clearly. And we also done recently a small study has been done in SCG now with our team there, along with Nimans, where we looked at heart rate variability during home chanting, especially. And we saw that with home chanting, the heart rate variability there's a more higher amount of relaxation response seen in these patients who did home chanting compared to Akara chanting or simply just chanting whatever they wanted to chant. Okay, right. And this is going to be published very soon. And I think it's been communicated to iJoy itself, I think so, recently. So this is one thing which we have experienced that this can be done. So going forward, when can patients do yoga? So patients undergo surgery, undergo chemo radiation, and they undergo immunotherapy now, and many other kinds of treatments. So when do you think it's safe for patients to do yoga intervention?
In fact, the answer to that question is your study, which you were the first person to do this study. On the day of diagnosis, you used to meet them and talk to them, tell them how important the mind is, because they were already going through those 4 phases of not accepting the diagnosis, then the anxiety, then the frustration, depression, future problem, all these you are able to address, not only by doing 10 minutes of 10 to 15 minutes or half an hour of counseling, but teach them the techniques to overcome that. As you gave that example, yes, however much we counsel them, their mind has to be silenced. They need techniques at the gross level, physical level, breathing level, mind level, emotions level, to be able to channelize that lot of chronic energy which gets locked up in that region due to anxiety and shift it down. So in your study, you did that. You started on the first day, just before they are entering into the hospital, you would have taught them some simple breathing, and they are already ready for surgery. So that time you were teaching them something to take through the post-operative period, because they will not be able to do physical postures. So you develop different modules, right from day 1, then during surgery, post-operative, during chemo, what are the sankalpas we should give during chemo, what are the sankalpas we should give during radiation therapy, while they are in the chemotherapy ward, while the drip is flowing, what are the techniques. So we have different set of modules for different phases.
Do you think, one more question is, do you think yoga can be used for symptom management in cancer patients?
Yeah, that's what is being talked about all the way along, and all the data has shown that symptoms management, pain management, fear management, anxiety management, all these are very important. And your publications on chemotherapy-induced nausea, vomiting, chemotherapy-related oral symptoms in oral cancer patients, all these you have been able to publish papers. So you should answer those questions better than me, Dr. Rao.
Yeah, thank you, ma'am. And
Dr. Rao, I would like to just add that as one of my slides showed already, that even Suchitra Mehta yoga, we have found that it reduces the side effects of chemotherapy, especially, in fact, a lot of patients, as we all know, they are so dreadful of chemotherapy that they said that I would rather die of disease than chemotherapy because it's very, very toxic. But people who were doing Suchitra Mehta yoga, they said, oh, we didn't even feel that we had chemotherapy. They went through it so smoothly with no vomiting, no nausea. Even their infections were much less compared to those who did not undergo. So yes, I think adding yoga definitely adds to the overall better quality of life and in all likelihood, better survival also.
ma'am, I think one more important thing when it comes to symptoms, I have a concern also here. And this is also for all the people who are looking at using yoga intervention for cancer patients. For example, a cancer patient comes to you with complaints of fatigue. So it's very, very important that we also have to look at their electrolyte levels. We also have to look at their anemia, basically. And anemia is very rampant in cancer patients because of the tumor itself, as well as because of the treatment as well, cancer-related treatment as well. So if a patient's hemoglobin is something around 4 or 5 gram %, physically able to do the asanas because it can lead to more aggravating their more amount of fatigue. So in such cases, what do you advise, ma'am?
As I rightly say, as you said, more important is the relaxation part. So we just start with deep relaxation technique, Shavasana. Breathing is the most important. And such people, they can't even do an hour program. We give them about 20 minutes of slow breath awareness, abdominal breathing, chest breathing, shoulder breathing, even lying in bed with Nadi Shuddhi Pranayama and Akara, Ukara, Makara chanting. We give them audio recorded instruction, ask them to do 15 to 20 minutes practice every 2 hours. Because many of these can be done even when the patient is lying is after food or after a drink, because none of them bring about any abdominal pressure. Normally the understanding is asanas are not to be done after food, but these are only relaxation techniques. So that's how we start off and then go on to adding physical postures comes much later. That's not the important component at all.
Yeah, this is very important because.
Can I
yes,
add
ma'am, please go ahead. Yeah, please, ma'am.
No, I would just like to say that as you were talking earlier, before this session started, that for such patients, I think rather than just basing our management on yoga, we have to use the integrative approach. I think it's very important that we increase the hemoglobin level by blood transfusion or whatever other treatment, and then add our yoga treatments. Certainly, Dr. Nagaratna, as she said, relaxation techniques would help. But important thing is to raise their hemoglobin first by whatever methods, whether allopathy. And allopathy is the only way you can increase their hemoglobin level.
Very obvious that it is integration.
Yes. So integration is important rather than just focusing on yoga.
Another concern which we also seen here, the two concerns here. One is on with respect to hyperventilation. Because when the people start doing hyperventilation breathing techniques like Kapalabhati, etc. Suppose the lesion is very close to the hilar region and the lung, and you're also receiving radiation to this. Do you think that we should take some precautions in avoiding this hyperventilation there, because chances of pneumothorax may also be there, because there's a literature which is suggested that one patient developed hyperventilation pneumothorax because of Kapalabhati. And you take on that, madam?
Because of?
Kapalabhati. There was a case report where they're shown, hyperventilation breathing. There's a case of pneumothorax because of hyperventilation. And this has already been published about 10 years back. So do you think that this can also be a problem if patient with a lung cancer, cancer very close to the hilar region, and the patient is receiving radiotherapy? This can also open up and cause pneumothorax?
Our goal is to take the mind to a state of calmness. Why we should do Kapalbhati only or do any Bhastrika? Do those practices which are doable, which are easy, which are comfortable, and make sure that the person's mind is taken care of, brought to a state of calmness, tonus, relaxation. Kapalbhati is not the yoga. There are 100 yoga techniques.
I would
Dr.
like to say,
Vinataji.
Dr. Rao, I would like to say here that this is where the importance of research lies. You know, many of our yoga techniques are still not researched properly. So it's important to know that which asana has what side effects, if at all. Most of us, we know that yoga does not cause side effects. As you mentioned that if pneumothorax can occur with any particular process, any yogic process, then it's important to study different asanas and see what are their actual benefits and what are their side effects. And then we can really come up with a definite answers as to which patient should be given what asana or which patient should not be given what asana. That will be even more important. Wait, for instance, when we give Sushruta yoga, we tell them that okay, patients who have, for instance, epileptic fits, we generally tell them not to do them. Supposing somebody has retinopathies, or supposing somebody has increased pressure in the eyes, glaucoma, we don't recommend them Sushruta yoga because we know that that can cause them harmful effects. So that is why I feel that it's important to know as to what are the definite benefits of which particular asana and which particular asana can cause problems to a particular patient and avoid it in them.
I think Sudarshan Kriya Yoga involves hyperventilation, Vastrika movements. That's what is Ravindra's question.
So that is why we avoid that in certain instances. Yeah.
This is the reason why I asked was one of my patients also developed this kind of hyperventilation pneumothorax, referred to me by Dr. Shekhar Patil because she was practicing all this Kapalabhati in Vastrika of late. And we had told her not to do that, but she continued practicing the same thing after a week. And one evening, I get a call from her husband saying that she has collapsed. And I told her husband to take the patient to the emergency room, emergency care center immediately, the nearby hospital. And this thing was right. It was a pneumothorax, and this can be one of the problems. Again, most of these patients have more of aromatase inhibitors. Again, the cancer can progress. You may have spinal metastasis. You may have metastasis to the bones. So there are chances of fractures. So this is one more thing where I think we should take a lot of caution to when you assess the patient, basically on what sort of interventions to give. Hyperflexion, hyperextension should be avoided probably in these cases sometimes.
Exactly.
Yeah, right.
Exactly.
Yeah,
I agree with you.
Yeah. So thank you all for this very interesting session. I also have Dr. Suchitra Mehta, who's also our panelist here. And she had a question for both Dr. Naharatna and Dr. Vinoda. Over to you, Dr. Suchitra Mehta.
So thank you, both the speakers, for wonderful session. And this is for you. Both are legends.
Not audible, madam.
And we know those because you preach.
No, you are blocked, madam. There was a lot of interruption in your audio. Please repeat your question.
Okay. Yeah. So my question is because what you preach is that you practice, like you practice first and then preach. So this is a personal question to both of your mind fit and alert. And what do you do yourself?
Yeah, I have been introduced to yoga when I was in medical school. And I used to do lots and lots of body bending those days. Later on, to more and more pranayama. And now I spend enough time. After COVID, I am spending 3 hours a day for my sadhana.
I didn't get the question very well. But what I do, yes, I do practice Darshan Kriya daily, which I preach to others also. And I find it that it has calmed my mind. It has helped me to take decisions properly. And it has taken away all my body pains and aches and etc. etc. And even though I have certain health issues like high blood pressure, diabetes, etc., but it's very easy to control them or keep them under control if I do regular sadhana in the form of Sushma Kriya, in the form of yoga asanas, in the form of meditation and pranayams. So yes, I
I'm
practice
sure
them, and then
you're 100% right when you started asking this very personally, but this is a message for all the listeners that if you are going to teach something, if you are a PhD person, you can only teach MSc people. If you are MSc, you can teach PSc. If you are MSc, for MSc, even school teachers need MSc today. So unless you are adapting your own experience, it becomes not possible to be a good teacher.
Exactly.
Very important message, Dr. Suchitra.
Yes.
Yeah, and thank you all for a wonderful session. And we had some 3 hours of session, and we are on the clock on 12:30. And thank Dr. Naratna and Dr. Vinodar for being here with us in spite of their busy schedules and amidst their patient day. I think Dr. Naratna is very busy today on Fridays because she sees all the patients of Shanti. Yeah. So I thank you, ma'am, for being here and educating all the people who are here with us. What was encouraging, what was the discussion we had from morning was to see that we develop a small program where all of you can be mentors to train Ayush doctors in various issues regarding integrating Ayush in cancer patients. Because today what's happening here is patients go to the cancer hospital, take their treatment and go back. They don't know what to do, whom to approach, what to do. And they don't have access to Ayush doctors. So Ayush doctors are also not aware of what they can do for the cancer patients. So if we can start bringing this awareness among Ayush doctors, and slowly we can look at, we can be hopeful of integrating Ayush modalities into cancer care and also start developing evidence for the same. So we will probably meet again with the same team and some more people so as to develop a integrative oncology program for Ayush doctors, which can be used as a certification program from CCRO and later on, so that this can help in developing a good amount of force where you can integrate Ayush modalities into conventional cancer care. So with this, I thank all of you and I thank all the audience who have been there patiently from morning and listening and have been interacting with the audience, with the panelists also, with a lot of relevant questions. And I thank you all. Dr. Anuja also is still here. Dr. Anuja Damani, namaskar, thank you. And thank you all the panelists and all my colleagues at CCRYN, Dr. Anusuya, Dr. Venkateswara Rao, Dr. Vajiraj, and many of them who in the vaccines, Mr. Vikas and Mr. Ram, who have been managing the social media as well here. I thank you one and all for your efforts in making this webinar a success. So thank you all. And let us end the session with a small Shanti mantra. Om Sarve Bhavantu Sukhinah Sarve Santu Niramaya Sarve Bhadrani Pashyantu Ma Kaschet Dukkha Bhag Bhavet. Om Shanti Shanti Shanti. Namaste. Thank you all.
Thank you. Thank you, Ravindra.
Thank you.